Acá. Buenos días a todos y a todos.
Good morning to you all.
Saludos. Con
Good
mucho
morning to you
gusto,
all. I'm
a
very
nombre del
pleased
Consejo, la
to
mesa
be here
directiva, nuestro
on behalf
presidente
of the Board of
Rodrigo
Directors,
Ruiz,
our
a este
chairman,
primer día de
to
la
this
Semana de
first day
Innovación.
of the week
Gracias a todas las
when we
personas que han
are
venido presencialmente y muchas gracias a
opening
todas las personas
this
que se han conectado.
Innovation Week.
Este es
Thank you
nuestro
for the people
séptimo
that are
evento.
here face to face
Muy
and the people that
contentos.
are connected
Tenemos una
remotely.
agenda
We
muy
are very happy.
importante
We have a very important
de
agenda
acciones y de
to discuss
actividades donde seguramente
actions,
habrá propuestas
activities.
concretas de impacto para el sector salud,
We will talk about the
beneficios de los pacientes, así
impact
que
for the
como
health
siempre es un gusto
sector.
recibirlos y para empezar
We
le
are
voy
very
a
happy to
pedir a Rodrigo
receive
Ruiz,
you
nuestro
here,
presidente, que dé su primer
and I would
mensaje.
like
Adelante, Rodrigo.
to ask Rodrigo, our president, to give his opening speech. Thank you very much. Good morning to you all. Thank you for being here. It is a pleasure to be here with you under this new way of having hybrid events. Years ago, life expectancy in Mexico, we have 46 years, but today is 72 years. 70 years ago, 50 million people all around the world were infected with smallpox. Today, we have eradicated it. However, the breakout of COVID-19, pharmaceutical research, the modernity, and the political will have contributed to great progress of world health. In AMIF, we know and we assume the great responsibility that we have in our hands, and we take it very seriously. Our companies research and develop drugs that change lives. And I ask you, what is more powerful than that? What a better way to contributing to the well-being of population? This great responsibility presents us great challenges and great expectations within the society so that we, as an industrial sector, comply with the highest quality standards in our drugs and vaccines, and also to guarantee an ethical behavior and high performance standards at a global level. In AMIF, as I said before, we take this very seriously. For our companies, it is very important how we do things, how we manage to fulfill our purpose. To be efficient, we depend on confidence and trust between doctors, pharmaceutical companies, hospitals, and patients. And I assure you that from AMIF, we work every day to honor that trust. In uncertain times like this, integrity has become a great differentiator. We are very proud that this is one of our most important pillars of the companies within AMIF. And just as Michael Josephson said, ethics is not a description of what people do. It is a prescription of what we all should do. And thank you very much to you all. Chris, please.
Gracias, Rodrigo, por tus palabras. Y ahora me gustaría presentar a
Thank you,
Patricia
Raúl,
Fassi,
for your
que es
words.
miembro
And
de la
now,
mesa directiva de
Patricia
AMIF,
Gassi, that
una
is
persona muy
member of the
reconocida
board of
en la industria,
directors in
una
AMIF,
gran líder.
very
Bienvenida, Pat.
renowned in the industry. Welcome, Patricia.
Muchas gracias, Cristóbal. Muy buenos días a
Thank you,
todos.
Cristobal.
Muchas
Good
felicidades
morning
por
to
este
you.
evento.
Congratulations for
Sin
this
duda alguna,
event.
ya es una tradición,
Beyond
es un
any doubt, it's a
recordatorio de la
tradition, it's a
importancia que tiene la
reminder of
innovación
how
en nuestras
important
vidas. Y en un área
innovation
tan,
is
tan
in our
trascendente
lives,
como es la salud,
in
pues
such
cobra
an
especial
important
relevancia.
thing in
Y bueno,
our
es desde esta
life,
visión ética
like
que nos
health.
ha hablado Rodrigo, desde
As
donde se
Rodrigo
nutre la
said,
innovación de
it
nuestras
is very
empresas, la
important
investigación
where
y
the
desarrollo que
innovation comes
realizamos
from, where
para
it
mejorar
is
la vida de las personas.
taking, where
Esta
are
visión
their
también es un
sources.
motor
This
que fortalece
view
el
is
crecimiento
also an
económico, la
engine,
aportación
a
de nuestra
driver
industria en ese rubro,
for
más allá
our
de la
industry
competitividad que se logra
beyond
por el bienestar y
competition.
la
We are
el estado de
always
salud de las
striving for
personas
the
es muy
well-being
trascendente.
of
Aumenta
people.
la competitividad de nuestro país, de nuestro sector,
Competition
fomenta
is
el
growing
comercio
in the country.
transfronterizo y
It
reduce las cargas regulatorias. Y lo que es más
encourages
importante, desde ahí
trade
es
and
desde
reduce
donde se
taxes.
fortalecen
And from
los
there,
sistemas de salud y se
health
mejoran,
systems
por
have to
tanto,
be
los
strengthened,
resultados para el
are
paciente.
improved. And of
Se
course, the
genera
results for the
confianza en los
patient.
sistemas de salud. Se promueve el acceso a
We
opciones
promote the
terapéuticas que
access to
salvan y mejoran
therapeutic
la vida de las personas.
options that can
Y se
save
impulsa
lives.
la
And
capacidad
we
para la
encourage
innovación. Se le da
the
energía
capacity
a
for
este
innovation.
círculo virtuoso, a
We
este
give
ecosistema
energy
que
to
se
this virtuous
retroalimenta para
circle,
generar
this
mejores
system that
opciones
is
para los
always
pacientes. Otro
feeding back
elemento
between
vital
doctors
que
and
nutre los
patients.
ecosistemas
Another
de innovación
element,
es la
pillar
propiedad
that
industrial.
nourishes it
La propiedad
is
industrial fomenta,
industrial
protege y
property.
reconoce el
This
esfuerzo
protects
creativo.
and recognizes the
Una patente
creative
crea
effort.
un mapa, crea un
A
antecedente,
patent creates a map,
consolida información
consolidates
sumamente importante
very
que
important
permite a
information
cualquiera
that
hacer lo
allows
mismo una vez que
everybody
esta
to
patente
do
expira.
the same
Las
thing
patentes inspiran
after it
innovación.
expires.
Y justamente
Patents
hoy es
inspire
el
for
Día de la
innovation.
Propiedad
And
Intelectual.
today
Y es
is
el
the
día
day
en
that
que está
we
dedicado,
celebrate
de forma especial o enfocado especialmente
copyrights.
al talento joven,
And
a los
it's
jóvenes creativos
focused
que
on
tienen la
young
ilusión de
talent,
cambiar el mundo.
on
Muchas
creative
felicidades para todos
young
ellos y
people
que
that
la
have in their
creatividad
hands
y
the
la
change
protección
of
a
the
su
world.
propiedad
Creativity
alimenten
and protection
este
to the
círculo virtuoso
copyright
de
must
creación
be
de nuevas
very
opciones.
encouraged.
La innovación futura es la clave para
Future
abordar las
innovation
necesidades médicas
is the key
no
for the
satisfechas de los
medical
pacientes.
to meet
Lo hemos
medical
vivido, ya se
expectations of
mencionó,
patients.
y lo
We
seguiremos
have
viviendo.
lived
Mientras haya investigación, se seguirán
this,
resolviendo
and we will
problemas
go
médicos.
on
De otra
living
manera,
it. With
estaremos,
innovation, we will solve
estancados en ello.
medical issues.
Y se
If
puede
not,
mejorar
we'll
la
be
capacidad y
stagnated.
sostenibilidad de nuestros
And we can
sistemas
improve
de
our
atención médica.
sustainability,
Sin la propiedad intelectual, la
sustainability
gran mayoría de los resultados
element.
innovadores,
Without
los
the
avances médicos y
innovation,
los
all the
medicamentos
advances,
genéricos de la actualidad
drugs, generical
no existirían.
drugs
Así que
would not
nuevamente,
exist. So
felicitaciones
again,
por este
I would
evento
like to
y
congratulate you
enhorabuena
for
por
this
este momento.
event.
Felicidades.
Muchas gracias, Patti, como dices, ¿no?
Thank
La
you very
importancia de
much,
la propiedad
Patty.
intelectual.
It is very
Claro, para
important.
acercar
Copyright is
innovación.
very important, and it
Creo que hemos
is
hablado
very
mucho
clear that
todos
it's
estos años y
fundamental.
hoy de
We have talked
innovación.
all these years, and we have
Y la
heard
innovación
a
tiene
lot
sentido si llega a los pacientes. Ese es el
regarding
tema más
innovation.
importante.
And
Hemos
innovation
sido muy
is
activos
focused on helping
en abogar
patients.
y
We've been
explicar cómo
very
nuestra industria
active
puede
to
contribuir
exemplify
a
how our
fortalecer los sistemas de
industry
salud. Pero para
contribute
esto sea una
to
realidad,
strengthen
necesitamos cambiar
health.
muchas
But to
mentalidades.
make this reality, we
Dejar de
have to
lado
change our
ideas
mindsets.
preconcebidas y seguir
It has to
construyendo
be
soluciones
clear
conjuntas
that we
y
have to
alinear
build
visiones
joint
sobre el valor de
solutions,
la innovación.
align visions
Por
of the
ejemplo,
value of
con
our
demasiada
business.
frecuencia,
For
los
example,
gobiernos se preocupan
very
más por el costo del
frequently,
tratamiento y la
governments
prevención,
are
pero rara
very
vez cuentan con el
concerned
costo de la
on the
inacción.
cost.
Es muy importante, una vez más.
And it
La
is
innovación es
important.
importante si llega a las
Innovation
personas que
is
lo necesitan.
important if it
Otras
reaches
tantas veces
all the
hemos
corners
escuchado
of
la agilidad, la
population.
promesa de la
Some other
agilidad
times we
regulatoria. Y
have
aún así,
promised
a las y
agility
los mexicanos
in
nos
their
toma casi 4.3 años tener
regulating
acceso a
bodies.
medicamentos
Sometimes
innovadores.
it takes
4.3
2
años
or
que son
3 years
1555 días. Este
to
plazo
get to the people.
está muy por encima de las mejores prácticas
More than
internacionales en la
1,000
región.
days.
ejemplo, en Brasil,
And it
se
is
lleva 2 años
below
tener
best
acceso a
practices.
innovación, la
In
mitad
Brazil, it
en
takes
Estados
2
Unidos,
years, half of the
Canadá y
time. In
algunos países de
United
Europa,
States,
1 año.
Canada,
Tenemos
Europe,
que cambiar
1 year.
esta
We
realidad.
have
Tenemos que
to
tener la misma
change
oportunidad que todos esos
this
países para
time
tener
framework.
acceso
We have to
a la
have the
innovación.
same
Para
opportunity
nuestro sector,
in
la
order to
agilidad
have access to
regulatoria y el
innovation.
acceso efectivo a la
Regulatory
innovación es
activity
una
and
prioridad.
access
El
to
reconocimiento
innovation is a
mutuo con otras
priority.
autoridades regulatorias
To
de
mutually
referencia a la
recognize
actualización del
other
Compendio Nacional de
regulating
Insumos para la Salud
agencies.
y su adopción en las
It is
instituciones,
very
así como
important
los
to
compromisos
adopt this new
adoptados
mindset and
por
the
nuestro
commitments
país
that
en
we
tratados
have
internacionales como
adopted
TEMEC son
in our
elementos que
country.
brindan una
In
plataforma
some
sólida
international
para
agreements,
avanzar hacia el
like
acceso
the
efectivo a la
TEMEC,
innovación. A lo
this
largo de estos
is a
días
solid
escucharán
platform to
el
have access
potencial
to
de la
innovation.
innovación en
During
distintas
these
áreas
3 days, you
terapéuticas.
will
Mucho de
hear
esto ya
about the
sucede
potential
en
of
otras
innovation.
latitudes.
This
Solo
happens
con el
in other
compromiso
countries
firme de todos los
only with the
involucrados
firm
en los
commitment of
ecosistemas
all
de salud
the
podremos hacer
involved
que las
in
y
these
los
health
mexicanos
issues.
tengan acceso a
We
esas
will
mismas
make it possible
oportunidades.
for
La
Mexicans to
innovación
have
no tiene
access
por
to
qué
this
ser lo que
innovation.
no tiene por qué
Innovation
ser
shouldn't
distinto a lo que sucede
be
en Estados Unidos, Europa y
limited
Brasil. La
to
innovación tiene
certain
que
people
suceder
and
aquí en
shouldn't be
México,
different from what
cambiando
happened
y
in
salvando
Brazil,
la vida
United
de los
States, or
mexicanos.
Canada.
Bienvenidos todos,
We
muchas
should
gracias.
make it
Rodrigo, muchas
accessible
gracias
to
Patti
all
por esta
Mexicans.
introducción.
Thank
Y ahora,
you,
sin más, me
Rodrigo, for
gustaría
this
presentar
introduction.
a
And
Robin
now
Norton.
I would like
Está
to present
conectada.
Robin Norton. I think
Good
she
morning,
is
Robin.
connected.
This is Chris speaking. Good afternoon for you. Let me introduce you. Robin es cofundadora y principal director del George Institute y nos va a hablar de enfermedades no transmisibles y género, datos para toma de decisiones. Thank you very
She
much
is
for participating,
co-founder
Robin.
and
The
director
audience
of
is
the George
really
Institute.
with high
Thank you
expectations
very
of your
much.
presentation. Thank you.
Thank you, Chris. Okay, well, thank you very much, Chris, for the introduction. And indeed, good morning, good afternoon. And for some of my colleagues from Australia who are joining us this evening, good evening. It's a pleasure to be with you today, albeit remotely. And I must firstly apologize for my lack of Spanish, so you'll just have to put up with my English. But I would like to thank you and your team for inviting me to make this presentation today. It's a topic about which I am particularly passionate, and in particular, data to make decisions for non-communicable diseases and women in particular. To do that, maybe all of you are aware of the importance of non-communicable diseases for women, but not everyone is. And I think I use an example here. I'm showing the UN Global Strategy for Women's, Children's and Adolescents' Health. And it importantly focuses on women's sexual, reproductive and maternal health, which of course is incredibly important, but it pays very little attention to women and non-communicable disease, which is quite extraordinary in many senses, given that we know that non-communicable diseases cause about 3/4 of all death in women globally. And of those deaths from non-communicable diseases, as you would see, a very large proportion of those deaths are amongst women, are as a result of cardiovascular disease. Indeed, if we look at some of the data from the Global Burden of Disease study published by the Institute of Health Metrics and Evaluation, we see that in the UK, of the 10 leading causes of death for women, 9 out of 10 of those deaths are the result of non-communicable diseases. If we look at Mexico also, that is exactly the same. Non-communicable diseases now account for 9 out of the 10 leading causes of death for women in Mexico. So non-communicable diseases are really important.
Okay.
So what does this mean in terms of what data do we have on non-communicable
Perfectamente, Carla.
diseases by gender? What data do we have on non-communicable diseases, especially for women? But before I look at some of that data, I thought it's really important to discuss some of the definitions that I would use and others would use. When we're interested in considering women and NCDs, we're interested in understanding both sex and gender. And by sex, we mean the biological and physiological characteristics that define individuals as either females, males, or intersex persons. When we're talking about gender, we're talking about the socially constructed roles, behaviours, activities, and attributes a given society considers appropriate for men and women. So when we start to look at sex disaggregated analyses of data, that enables us to identify the biological differences between females and males. When we're considering gender disaggregated analyses, that enables us to identify disparities between men and women, as well as gender fluid and non-binary persons potentially, that relate to the impact of socio-cultural and economic factors. In reality, we're interested in understanding both the biological factors and the gender factors that impact on the incidence and outcome of disease. In practice, what we find is most of the data that we would have would be self-identified gender rather than sex, but people use these terms interchangeably, and as you'll see in my presentation, I will also, albeit we do understand there are differences between the two. So what data do we have? Well, historically, if we look at cell-based research, we see in much of the published research that sex has not been specified. If we look at animal-based research, we see that a large proportion of the animals used in such research are male. If we look at human research, and in particular human trials, we see a greater proportion of women involved, but still not in proportion to the numbers of women in the population, and often not in proportion to the disease burden. If we want to then look at, well, what do we know? Oops, I moved a bit too fast there. If we want to then understand, well, what do we know about women and NCDs and the data that are available, I want to share with you a recent publication from some of our team at the George Institute, which showed that in analysing women's health journals and general medical journals, it is still the case that women's health publishing remains largely focused on reproductive health topics rather than the diseases that kill or disable women. What we saw in this analysis that was undertaken in the women's health journals, reproductive health topics increased to 49% in 2020, and in general medical journals to 47% of the articles. Indeed, articles on cardiovascular disease, the leading cause of death for women, comprised only 15.5% of the articles in women's health journals and 7.5% in general medical journals. But let's move on to the underrepresentation of women in medical research and trials and in NCDs specifically. I showed you before that women have historically been underrepresented in medical research, and that is true for NCDs. And again, some recent work from our team at the George Institute showed that this was also true for women in trials of stroke. Whereas 48% of all strokes occur in women, only 37% of trial participants are women. And in a previous report by the same authors on the same data, only 36% of trials reported analyses by sex, of which only 33% were pre-specified analyses. So, well, does it matter? Do we need to collect and analyse data by sex and gender? And if we do, how can this potentially benefit women and men? What I want to do in the next few slides is, again, provide you with some examples from the work that we've been doing at the George Institute, which really focus on better understanding differences between men and women in prevention and differences in treatment. But let me start by showing you an example that arguably might mean a lot more to many of you in the audience. I think many of you would be aware that most drugs on the market have been approved from clinical trials conducted only or predominantly in men. And even when women are included, data are seldom disaggregated and reported by sex. So it's perhaps not surprising then that women experience adverse drug reactions nearly twice as often as men. Sex differences in pharmacokinetics strongly predict sex-specific adverse drug reactions for women, but not men, which is not explained by body weight. So most current medication practices risk over-medication of women, leading to greater risks of adverse drug reactions. But let me now turn to some of the work that we've been doing, focusing specifically on NCDs, and in this instance, an example from some work that we have done in stroke, using data from the UK Biobank. That work showed that even though the incidence of stroke is higher in men, some risk factors are more strongly associated with stroke risk in women than they are in men. In particular, smoking, hypertension, and low socioeconomic status. An earlier piece of work, also undertaken by our team, focused on diabetes. It used data from an analysis of many large-scale cohort studies and large-scale data sets, and showed that for women with diabetes, compared with men at diabetes, they were at 44% increased risk of heart disease. Likewise, women with diabetes were at much greater risk of stroke than were men. Turning now to looking at treatment effects. Again, work from the Institute, this time using data from the US. It showed the percentages of men and women who were appropriately prescribed statins after hospital discharge following a heart attack was much less in women than in men. Now you might say, well, does this really result in any major mortality differences? Well, and I like to quote a report that the British Heart Foundation produced a couple of years ago, which really focused on a range of research that has looked at the gender gap in heart disease. And in particular, they quoted a piece of research that they had funded, which suggested that between 2002 and 2013, over 8,000 women were likely to have died because they did not receive the same standard of care as men, even though they were both been using guidelines. So this has really important implications for health outcomes in women. I'd lastly like to present one last piece of research, this time done with our colleagues in China. And this time, it actually shows disadvantage for men. So doing this sort of research not only is beneficial for women, but potentially beneficial for men. In this study, a systematic review of 57 studies, in both men and women, awareness, treatment, and control of hypertension was low, but it was much lower in men than it was for women. So what does all of this work mean? Where do we go to next? We're starting to get data on NCDs for women. We're starting to see quite clearly that there are significant differences in awareness, in diagnosis, in presentation, and in management of non-communicable diseases for men and women. But where do we go from here? And I'd perhaps like to draw your attention on the right to a recent journal, a whole journal issue of circulation research that focused particularly on women and cardiovascular health. And the editorial accompanying it made some really important comments, which are relevant not just for cardiovascular health in women, but also non-communicable diseases and women's health generally. That article talked about we need to go the next steps from describing the problem to identifying differences to really a need for a greater understanding of both the biological mechanisms that account for sex differences in NCDs and the gender-specific factors that play a role in inequitable outcomes. But perhaps most importantly, we do need to go from describing the problems, understanding why those differences occur, to developing effective sex and gender-specific interventional approaches to both reducing risks of disease and managing disease. We need to be identifying better treatments and better ways of access to care for both men and women. But I come back to the original premise of this presentation, the need for data to make decisions. And one of the ways that we are going to be able to make better decisions about women and NCDs is by the development and implementation of policies by funders, by medical journals and other relevant bodies requiring the integration of sex and gender analyses in research. The Canadians, the US National Institutes of Health, and most recently now, the EU have such policies. And the Canadians have shown after 10 years of introducing these policies that the policies make a difference, that research reporting the integration of sex into research has risen by 83% and gender to 33%. But not all constituents have these policies. And frankly, my colleagues in Australia, we don't have it. My colleagues in the UK, we don't have these policies. So I'm very pleased that we've recently received philanthropic funding in Australia and funding from the Wellcome Trust in the UK to now look at co-creating policies with funders of medical research to ensure that in the future, the data that we have from medical research is disaggregated by sex and gender and provides us with the information that we're going to need if we're going to improve health outcomes for women and for men. Thank you very much. It's been a pleasure to speak to you today.
Agradecemos a Robin Norton su participación. Tenemos 5 minutos
Thank
de
you,
descanso
Robin
en lo que
Norton, for
comienza
your
el siguiente
participation.
panel.
We
En la
really
parte de afuera hay
appreciate
una
her
mesa
being
con
with
café
us.
y
There will
bocadillos.
be a
Gracias.
break. We have a coffee break service outside.
Gracias, los invitamos a tomar sus lugares. El siguiente panel está por comenzar.
¿Cómo avanza la presentación, Carla?
¿Cómo va a ir avanzando la presentación? Buenos días a todas y todos. A nombre del Instituto Nacional de Salud Pública, quiero dar las gracias a MIF por invitarnos a participar en la Semana de Innovación AMIF este año 2022.
For me to participate in this Innovation Week. It is an honor for me to have been invited and to conduct the first panel of this session. Chronic diseases, we heard Dr. Norton, represent a disease burden, very important around the world. But in Mexico, the relevance of this element is greater every time because we are going through a technological transition, and this disease burden has been occurring and have been affecting and impacting the population, and gender has been very important. This health burden is an economic burden impacting all the country and all the population. That's why in this panel we are happy to launch the economic and health impact of non-communicable diseases in Mexican women. This gender vision is very important. This is a collaborative project of the National Institute of Public Health and the George Institute of Australia. We have been working jointly and have received very good support. Here we are going to discuss the relevance of this subject. To start, I would like to present Dr. Eduardo Lascano, General Director of the National Institute of Public Health, and he has recorded a message that we will present in a moment. Doctora Carla Baez is also going to participate. She represents Access to Innovation in AMIF, and they will talk about the outcome of the project that I just mentioned by Dr. Manori and Emmanuel Orozco, that are researchers of the Center for Investigation. And finally, to close the panel, Robin Norton will also be part of this group, and she will talk about the launching of this project. So I would like to see Eduardo Lascano's message.
Todos y todos, a nuestros amigos de la Asociación Mexicana de Industrias de Investigación Farmacéutica.
I would like to appreciate our friends of the AMIF. I would like to say that the National Institute of Public Health was created 35 years ago. We are going through a mature transition. Last year was a very important year, almost 420 academic products.
8 de cada 10 de los artículos que publicamos tiene una colaboración internacional
were researched and developed, and 8 of them have an international impact. We have a great impact in our research groups. The National Institute of Public Health has been evaluated by CONACYT that it is the most influential organization in the medical sector in Mexico. This has happened during the last 5 years. Our products have more than 70,000 bibliographical quotes, and it represents a great growth. We also have a magazine in Mexico, and it has existed for more than 65 years, and it is considered by CONACYT as the best scientific magazine. In addition, in 2022, we are celebrating 100 years of the National Public School. It has granted many degrees during its history, and for this region, our institute participated with scientific evidence, a very robust one in the health sector. It has a very high standards, ethical standards. In this context, I would like to send my greeting to AMIF,
por su acrónimo conocida como la AMIF, porque identificamos áreas de
because we
investigación de
have
interés común
identified
y en el marco de la
common
semana de innovación
research
denominada
areas,
la
and
transformación del sector
during
salud,
this
aportaciones de la
innovation
industria
week,
farmacéutica,
the transformation of the health sector, we have made a great contribution presenting the outcome of the economic and health impacts of non-communicable diseases in women. Edson Servan Mori is one of the most important elements. He had a collaborative mission with the George Institute in Australia and has the sponsorship of it. I would like to talk about it. This is a research program with a mixed methodological approach to evaluate the economical impact, the differentiated impact between men and women. In particular, we would like to communicate this impact due to these diseases and go into further detail the prevalence of them, emphasizing the difference in gender and social aspects. I really appreciate your attention, and thank you very much for your attention. I really appreciate it. Dr. Lascano, thank you very much for your video. And now I would like Dra. Carla Baez to talk about the vision and mission.
Adelante, por favor, doctora Baez.
Hola, muy buenos días. Pues bueno, primero que nada agradecer tanto al auditorio que está aquí presente con nosotros como a los que nos tienen la oportunidad de vernos de manera virtual ahora. Es lo ideal. Antes que nada, por supuesto, agradecer al Instituto Nacional de Salud Pública su estancia, ¿no? Y además su enorme participación en este proyecto. Por supuesto, la misión y la visión de AMIF tiene que ver con todo, con la parte de investigación. Por eso cuando nos propusieron definitivamente tener un proyecto con dos instituciones de esta magnitud como son Salud Pública y el George Institute, definitivamente no tuvimos nada que pensar. Para nosotros simplemente fue natural poder apoyar este tipo de estudios y por supuesto estar presentes.
Of course, we sponsor this kind of researchers and studies.
Con información es esencial. Es parte de la toma de decisiones, parte del objetivo que estamos buscando. Que la
I'm
toma
sorry,
de decisiones
I
sea fundada
cannot translate.
en elementos de información seria.
I'm having trouble getting the original language.
Es tan relevante todo esto que venimos platicando alrededor de las diferentes sesiones. Bueno, pues voy a permitirme dar algunos números nada más.
I would like
para
to give
empezar,
some numbers.
Según el INEGI, somos el 51.43% de mujeres. Solamente en la Ciudad de México
51.4%
superamos. Estamos más o menos en 52.5%.
of the population
Todos
in
los demás
Mexico
estados son más o
are
menos al promedio, pero en la Ciudad de
women.
México en particular somos más del 52%
So we
de
represent
mujeres
women
que estamos
more than half
participando,
of the
¿no? en la
population
economía,
in the
y, por supuesto,
country.
estamos dentro del país.
So we impact
Puede
the
sonar
economy in a
incluso
very
algo
important way.
paradójico, pero también la esperanza de vida de las mujeres es mayor.
Life
No, la esperanza de vida
expectancy for
comparada con
women
los hombres
is
definitivamente
also
mayor,
greater
pero
than men.
desafortunadamente el
But
32%
unfortunately,
de esa esperanza de vida o de esa vida
a
la
great
pasamos
percentage
mal,
of this
no con
life
problemas de salud.
expectancy
Les voy a dar nada más
or the
cinco
life that a woman
puntos,
lives
¿no?
is not
información
very comfortable,
internacional.
and they have exposed to
Desafortunadamente
different
nuestra
ailments.
información local es bastante escasa.
will talk about 5 important things. 2 out of 3 women death is due to non-communicable diseases. Cancer, depression, autoimmune diseases, hypertension, and we are 52% of the population. Most of people with HIV are women, especially young women under 24 years old. There are some other diseases that are also much more frequent in women than men. In communities, in households, women are in charge of taking care of the family, and that's why it has also a greater impact in the life of the country. And this impact is not reflected only in the medical sector. It can also be seen in the social sector, in the economic sector. And sometimes, even when women are not only contributing with money to the economy, they participate with care for children, for the family. That's why we consider it very important to participate in this kind of researchers. We have to study to make researchers to prevent, always be aware the gender differences that are in the population. And now I will give the floor to our researchers that are here with us today.
Nos gustaría ya presentar los resultados preliminares.
I would like to present the preliminary results of the projects that are launched today.
Para que inicie y después el doctor Emanuel Orozco hará el complemento de la presentación.
Dr. Emanuel Orozco, please.
Muy buenos días a todos y a todas.
Good morning to you all.
Para mí y al igual que para el equipo de investigación es
un
verdadero placer estar
and my research team, it's very important to be in this Innovation Week to launch this research project. This is very important for us, particularly, but also the institution that we represent. The inequity in health and vulnerable groups is a very material aspect, not only for our institution, but for all the country in our role as influencing agents in public policy. Today's project is called Economic and Social Impact and the Development of Non-Communicable Diseases in Women. Can you please show me the presentation? I would like to see the slides. We have so many screens.
Gracias. Entonces les decía que el día de hoy
So I
nos es
was
muy grato
telling you
presentar o
that
lanzar el proyecto
it is an
titulado
honor
Impactos
for
Económicos
us
y de Salud
to
de
roll
las
out
enfermedades no transmisibles en
the
mujeres en
economic
México. Es un proyecto
and
de
health
investigación
impact
que está en
of
curso
non-communicable
y se va a
diseases
desarrollar
for
por los
women in
siguientes
Mexico.
ya
It
18 o
is
17 meses.
underway and will be rolled out in 17 or
La
18
siguiente, por favor.
months. It's been under this research phase and stage still.
Es un proyecto que indudablemente no se hace con pocas personas. Es un
A
proyecto
project that
colaborativo, como ya bien se mencionaba hace un
needs the collaboration of many people.
y que incluye
And it
varios
includes
académicos y varios
several
colaboradores del
scientifics and
instituto.
collaborators.
Tenemos un equipo multidisciplinario conformado por
Cross-functional
no
team is the
solamente
one that
científicos de las ciencias
really
sociales, sino también de
is
las ciencias de la
involved, not
salud,
only in the
epidemiólogos,
social
etcétera.
sciences, but
Pero
also
también tenemos
biological
la participación de
sciences.
colegas
We have the
del
participation
George Institute de
of
Australia,
some colleagues
así
from the
como
George
otro tipo
Institute in Australia
miembros en el equipo.
and other members of the team.
Yendo, la siguiente, por favor.
Next slide, please.
Yendo directo al planteamiento de la investigación o a la racionalidad de la investigación.
About the rationale of the research. I wouldn't like to go into further detail of the previous details, just telling you that it is important to talk about the importance of researching this in women due to reproduction and other factors. The importance of talking about inequity in gender and health, it is well documented in literature. It is important to see this element. The differences between genders are expressed in health issues that go beyond the biological definition between men and women. The gender goes beyond several aspects, social especially, because there are many inequity, a lot of inequity in structures due to reproduction. Should I use this device to see the next slide?
Perdón. Bueno.
Oh, okay, I get it now. So gender interacts with economical and biological determinants and, of course, risk factors of lifestyle for communicable diseases.
La forma en que las mujeres experimentan
how women live these diseases have not received enough attention. And this can be seen in the day-to-day life. For example, policies that are not sensitive, social regulations that are not sensitive for women. We would like to talk about this economic burden of non-communicable diseases from the gender perspective. We would like also to inform the different policies that should be put in place to improve savings and health care implementations. The most important research questions that we have are the following. The first one, which is the health and economic burden of non-communicable diseases in men and women? Although it looks obvious, it has not been analyzed as it should be. And how us, as researchers, how can we support our peers to produce efforts in prevention and handling of these diseases, spotlighting the Mexican women? The general objective then would be to analyze from a gender perspective, thought as the strategy to mitigate or reduce
en las enfermedades
inequity
transmisibles difiere
in health,
entre hombres y mujeres para el caso mexicano.
and how the
Además de
differences
comprender el
impact
contexto
between men and
político y
women, and
sistémico
also
en materia de
understanding
sistemas de
the
salud,
political
en el que
environment in
existen las
terms of
desventajas
health,
experimentadas
where
por las
there
mujeres
are
y
some
formular sobre todo
disadvantages that women
recomendaciones
live.
efectivas para abordarlas. Específicamente,
Specifically,
lo que
we
buscamos
have
son
some
realizar
objectives.
5 objetivos. El primero de ellos, analizar
We
las
have 5
tendencias
of
de la
them
carga de
to
las
analyze the
enfermedades
trends
no
of the burden
transmisibles,
of these
distinguiendo
diseases,
por hombres y
making a
mujeres.
differentiation between men and
Enseguida,
women.
analizar las disparidades de
Next,
género en
analyzing
algunos
the
trazadores de
disparities
desigualdad social como
between
son la
gender
protección social y
in
financiera
social
y
protection,
el
financial
acceso y
protection,
uso a los
and access and
servicios de
use
salud
to health care
asociados a
services
las
in
enfermedades no
Mexico
transmisibles.
related to non-communicable
Como tercer
diseases.
paso, buscamos
As
estimar
the
el impacto
third
económico de estas enfermedades en mujeres
step,
derivadas de la
we
pérdida
would
de
like to
productividad por
estimate
muerte
economic
prematura o
impact
morbilidad.
of these kind of diseases due to lack of
Como
productivity,
objetivo 4,
premature
analizaremos las
death, and
políticas de salud de
morbidity.
las últimas
Number
2
4, to
décadas
analyze
relacionadas con las
health
enfermedades no
policies
transmisibles,
in the
la
last 2
respuesta organizada del
decades
sector salud
related
y
to
áreas
non-communicable
complementarias.
diseases, and the
Y
answer
finalmente,
in the health
analizar las
sector,
experiencias socioculturales
and also
de las
analyze
personas que viven
sociocultural experiences of
considerando como
people
enfermedad atrasadora a la
living
diabetes en
with
diferentes contextos sociales y
diseases
económicos
such as
para comprender
diabetes
los factores
in
de
the
género
social and
relacionados con su
economic
prevención y tratamiento.
level, and seeing how
Los
we
métodos.
can prevent these diseases.
Este
Which are
proyecto
the
es un
methods?
proyecto de diseño mixto,
This
se conoce así
is
en el ámbito académico, con
mixed
perspectiva de
design
género.
research
Diseño
with
mixto
gender
en el sentido
perspective.
de que involucra
This
la
is in the sense that
implementación o
it
el uso
involves
de
the implementation
diferentes métodos,
or the
tanto
use
de
of
tipo
several
cualitativo como de
methods,
tipo
qualitative
cuantitativo.
and quantitative.
Las enfermedades sobre las cuales nos vamos a centrar
Diseases that we
están
will be
divididas en 5
focused
grupos.
on
Diabetes mellitus
are
tipo
divided
2
in 5
en el
groups.
primero,
Type 2
cánceres y
mellitus
neoplasias,
diabetes,
enfermedades cardiovasculares
cancer,
crónicas, enfermedades
cardiovascular
respiratorias
chronic
crónicas y
diseases,
enfermedad renal crónica.
respiratory chronic diseases, and bladder disease.
Listo. Les decía que en términos generales el
I was
proyecto
telling
se
you that
divide
in
en 5
general
componentes.
terms,
El
this
primero de
project is
ellos
divided into
involucra
5
la
components. The
indagación
first
o el
one
establecimiento del estado del arte
involves
en
the
torno a el vínculo entre el género, la
establishment
salud, la carga
of
económica y
state of the
social.
art in terms of health
Luego,
and the social burden.
el segundo componente
The second one
involucra el análisis de la carga propiamente
is
dicha
the
de las
analysis
enfermedades no
and the
transmisibles,
burden
perdón, sí,
itself
no
of the
transmisibles, y el análisis
non-communicable
político.
disease,
Enseguida,
and
el
also the
tercer componente
political analysis.
involucra
The third
la
one
protección social y salud,
involves
acceso y utilización
social
de servicios de
protection,
salud. El cuarto, la protección
social
financiera
health
en salud.
protection,
Y el
access and
quinto, las
use of
dimensiones sociales
services,
y de género detrás
financial
de la
protection,
experiencia
and
de
the
vivir como
social
diabetes.
dimensions
Ojo, la diabetes
and
empleada
gender
como
dimensions
enfermedad trazadora.
behind the
En
experience
particular,
of
tenemos
living with
ya avances
diabetes.
en los componentes que ven subrayados en el
In
estado del
this
arte, la carga de las
component, state
enfermedades
of
no
the art,
transmisibles y
burden,
análisis político y la protección
political
financiera en salud.
analysis, and
Más
financial
adelante,
protection of
el
health
maestro Orozco
will
va
be the
a
ones
detallar un poco al respecto
that
y va a profundizar también
will
sobre
be
el quinto componente y el propósito y de lo que se va a
approached
tratar.
by myself.
La aproximación analítica,
And the
les decía que para el primer
following
componente
speaker will talk about the last part.
Estamos realizando la revisión
In the
del estado
first
del arte y un
component,
análisis
we are
documental.
reviewing
Se conoce como
state of the
revisión
art
de literatura estructurada
and reviewing
para
structural
responder dos preguntas
literature
bastante puntuales.
to answer
¿Cuál es la
two
carga
specific
social y económica de las
questions.
enfermedades
What's
no
the
transmisibles en mujeres
social
y
and
hombres?
economic
Y
burden
además,
on
la segunda pregunta,
women? And the
¿cuáles son
second
aquellos
question,
factores
which
sociales,
are
políticos
those
y
social,
sistémicos que
political, and
influyen sobre
systemic
esta
factors
carga?
that have an impact on
Enseguida
this
vamos
burden?
a realizar, o ya hemos iniciado el componente analítico cuantitativo.
We have also
que tiene
started
como
with
objetivo,
the quantitative and qualitative
les decía hace un momento,
aspects,
analizar
and the
las
objective
tendencias
is
en
to
la carga de la
analyze
enfermedad,
the trends
evaluar
in the
las
burden,
diferencias
to
o las
evaluate
desigualdades o
the
las disparidades en
differences
materia
or
de
the
protección social y
differences
financiera, acceso y uso a los servicios de salud
of the
por
access
sexo,
to,
la pérdida de
to
productividad por
the
muerte y
economic
morbilidad vinculable a esa enfermedad
life,
no transmisible
to the
también.
health services
Y
between men and
finalmente,
women.
como parte del
And
análisis
finally, as part
cuantitativo,
of the
se
analysis, the
pretende
quantitative
realizar un mapeo
analysis,
político y un análisis
to have a
etnográfico para
political
profundizar
mapping, a
en el rol del
geographical
género en la
study
determinación de la salud
based
y
on
su
gender
carga social y económica.
and the social and
De mi
economic
parte sería
burden.
todo. Le doy la palabra, por favor, a
So now,
Adelante.
I would give the floor to Manuel.
Muchísimas gracias, Elton. Muchas gracias a todos.
Thank you very
Nuestro
much
proyecto
to you
cuenta
all.
con un
Our
comité
project
asesor.
has
Este
an
comité asesor
advisory
está integrado por
committee
personas de la
board
sociedad civil, del
that
ámbito
has
académico.
the
Y
teaching sector,
nuestra
the
idea
civil
básicamente es que este comité
society,
asesor
and our
nos ayude
idea
con
is
ideas
that
para
this
poder
committee
difundir de manera
supports us with
efectiva los
ideas
resultados y además como que nos mantenga con los pies en la
disseminate
tierra,
the
no estar
information and
opinando
keep
sobre lo que
us
se va
grounded
obteniendo y vamos a tener ya
regarding
próximamente
the
la semana entrante de
outcomes.
hecho nuestra primera
Next week,
reunión
we
de
will
trabajo.
have our first work
Ahora
session.
sí, este proyecto como
This
parte de
project
sus alcances
regarding the
lo que busca son 5 cosas, ¿no? En un primer momento, y le
approaches
apreciamos mucho el apoyo de
is
AMIF y del
looking for
George
several
Institute,
things,
es
and we
consolidarse como
appreciate
uno
the
de los
George
primeros
Institute
estudios que va a fondo en el
collaboration. This is
análisis
going to
de
be
cómo
one of the
influye el
first
género en las
researchers
enfermedades crónicas.
studying how
Al mismo
gender is
tiempo, es un
important
proyecto que
in
se
chronic
propone
diseases.
generar
At the
información
same
robusta y
time, it creates
rigurosa
robust and
para
rigorous
producir
information
productos científicos
to
de alto impacto.
produce high
Buscamos
impact
también ser un
scientific
laboratorio
projects. We
colaborativo
also want to
para
be a
poder diseñar
collaborative
intervenciones efectivas de
lab
alto impacto,
for
convertirnos en una plataforma colaborativa
high
y al mismo
impact
tiempo
decisions.
generar
Being a collaborative
expectativas de
platform
trabajo de mediano y
generate
largo alcance.
work expectations
Como
in the
estrategia de
short and
comunicación,
middle
estamos
term.
trabajando de manera conjunta
We
tanto
are
AMIF
working
como,
together,
el
AMIF
instituto y el George Institute, y
and
tenemos
George
ya una estrategia
Institute,
para poder
and we have
difundir
already a
resultados de
strategy to
investigación en foros
disseminate the
importantes como este. A
outcome
continuación
of
les voy
the
a presentar algunos
studies.
resultados.
And I'm going to show
Tenemos un
you
trabajo
some of
también de
them.
prensa que
We
estamos
also
haciendo de
have
manera
some press
colaborativa
work that
y
we are
también
doing in
integrando
a
una
joint
red de
way,
trabajo,
are integrating
buscando
a
medios modernos de difusión,
networking
como son nuestras
using
páginas
social
electrónicas,
media,
Twitter, Facebook,
web
etcétera.
pages,
Y ahora sí,
Facebook,
ahí les van
etc.
algunos de los primeros
And
resultados
here
preliminares.
are
En
some
nuestra
of the
búsqueda en
most
literatura
important
tenemos
things.
ya revisados
We have
5
reviewed
bases
in
de datos
literature
muy
5
completas, y en
databases
esas
that are
bases de
very
datos
complete. And in
hemos
those
revisado ya más de
databases,
5,000 resúmenes,
we
de
have
los cuales solo el 7%
collected
da muestra de
5,000
un
summaries.
enfoque integral de género. Podemos decir que el
And only
mainstream lo que
7%
tiene es
of
un
them
enfoque binario, muy
are
biologicista,
focused
y en
on
donde
women.
todavía
The
resta
mainstream
abordajes de
goes to the biological part of it
alcance
and
más
not the
integral como el que
gender part,
nosotros
a
estamos
more wholesome approach.
Para mostrarles datos de la
To
carga de la
show
enfermedad, en materia de carga de la
information
enfermedad, uno
of
de
the
nuestros
burden of the
resultados más
disease,
relevantes
one of
es
the
que
most
las
relevant
brechas de
results
género
is that
en
the
este
gender
tópico
gaps
se van reduciendo,
here
van siendo menos dramáticas entre hombres y mujeres,
are being less
exceptuando
dramatic
algunas
between men
condiciones en
and
donde
women
involucra trabajo
regarding
doméstico, como es el caso
conditions
de la
that
EPOC, ¿no? La preparación de
include
alimentos, usando
domestic work, for
biomasa.
example,
Y tenemos también, por
EPOC,
supuesto, expectativas
and
importantes
biomass
en lo
is
que son
also
factores de
important.
riesgo como
We
el
have
consumo
risk
de tabaco y
factors
alcohol.
as
Y un dato
tobacco,
negativo en materia de
alcohol,
género
and a
que es,
negative aspect in
una
terms of
menor
gender
práctica de la actividad física en mujeres.
is that
En
women
cuanto
do
a lo
not
que
work
es,
out as much
nuestro
as men.
trabajo de
Regarding
carácter político, en materia de mapeo
the
político, lo que
political
estamos encontrando
aspects,
es que de
we
manera
have
inicial,
found
cuando nosotros
that
abordamos el
at the
tema de
beginning,
género
when we
y
started
en
approaching the
México,
gender
lo que tenemos es como un concierto de actores muy
subject,
amplio desde organismos
we have
internacionales,
several
organismos de la
actors,
sociedad civil y algunas
international
secretarías de Estado,
bodies,
pero
civil
cuando ponemos ya
organization,
enfermedades crónicas, esto se circunscribe
players.
básicamente
But when
a
we talk about
resultados,
chronic
artículos de carácter
diseases,
académico,
it's
y llama
only
poderosamente la
limited
atención que
to
el
the
tema de género
publication of
como tal
articles
no
and
sea tan
magazines,
visible, ¿no? Lo que
but
predomina es más
talking about the gender differences is not approach. We talk more about gender when we talk about politics or accidents or violence. And now, regarding the economic part and the assurance, we have found some relevant things. In the last 20 years, the percentage of households led by women increased in a 25%, and most vulnerable households are the ones that are led by a woman. In those kind of households, the expenditure of accidents or catastrophes are greater, and if when there is an elderly feminine person, it increases. The burden also extends, amplifies inequities, and generates a greater burden, and it demands a cross-functional and collaborative work to have a better gender perspective and have better practices in our country. Thank you for your attention, and I'm open to your questions and comments. Thank you to the researchers of this project that presented all these results. They have presented us a whole challenge with the findings in Mexico to support these kind of diseases with gender perspective. Now, Dr. Norton, being Mexico the first country in Latin America, the George Institute will be focusing on gender. For you, what's the relevance of data in Mexico? What is your opinion? What should be the plan for Latin America as a region? And we would like to have your opinion in this regard.
Thank you. And firstly, my apologies yet again. I feel so bad that I cannot speak or understand Spanish. Emmanuel is very good at translating when we have our conversations, as is Carlos, our other collaborator. But so my apologies if I do not respond exactly to the questions you put to me there. But let me say, the George Institute, and I should say beyond the George Institute in Australia, but with the George Institute globally, because we have teams in China, India, and the UK as well as Australia. We're thrilled to be undertaking this collaboration, both with INSP and with the MIF. This collaboration is consistent with our mission to improve the lives and health of millions of people worldwide. It's consistent with our plans to collaborate more with colleagues in Latin America, and frankly, it's also consistent with our Global Women's Health Program. We feel that this is an opportunity for us to share our experiences and learning, but equally to learn from our colleagues in INSP and to share their learnings and their experiences. I think we're thrilled that the partnership that we have here is, I think, as my colleagues have mentioned, it's very much a multidisciplinary team. From the George Institute, we have individuals who've got strong epidemiological backgrounds. We have individuals with strong economics backgrounds. We've got individuals who are health systems researchers. And we're very fortunate to have our Director of Impact Engagement who really will facilitate working with our colleagues to ensure the findings of this research impact more broadly.
y cómo es que
I'd
todo
like
esto
to
impacta
make
más
a
a
comment
ellas.
that I
Me
really do
gustaría
commend
hacer un
Amif for
comentario
supporting this work.
importante y
As
yo
I
apoyo
indicated in
totalmente a
my
este grupo.
presentation earlier
La
before, it
presentación
is
que
really
di
important
antes
that funders
es
recognize the importance of including women in research, the importance of undertaking sex and gender aggregated research, and of course the importance of NCDs for women. So it's fantastic that AMIF have recognized the value of this work and the collaboration that will emerge between INSP and the George Institute. I'd also like to say that for us, we feel very privileged working with INSP. It is one of the leading research institutes, not only in Mexico, but in Latin America. So that is an enormous, it's part of the reason we want to be part of this collaboration. I mentioned before our Director of Impact and Engagement, and as Edson and Emmanuel would know, we feel developing and establishing an advisory group to this study of representing individuals who are passionate about women's health, who are passionate about women and NCDs, and can ensure that the results of this research are not just a piece of academic research, but actually have an impact on policy and practice. So let me stop there. I think most importantly, this is a fantastic piece of research, got a great collaboration. It's interesting to see Edson and Emmanuel in person and Carla in person. We're used to seeing each other on the screen here. And I look forward in the future to actually meeting in person beyond today's meeting. Thank you.
No sé si me puede poner, ¿sí? ¿Se escucha?
Sí.
Ah, perfecto. Muchísimas gracias, doctora Norton, por esta perspectiva más amplia de México, Latinoamérica, como región, pues tenemos que pensar
regarding
también en estos términos,
Mexico,
porque
Latin America,
compartimos
all the
mucho la
region,
carga
we
de
have to
enfermedad
think
y
in this
también,
term because we
pues, la
share the
necesidad de
burden of the
establecer
disease,
estrategias
and we
que
need
sean
to establish also
aplicables para
the
toda la región.
strategies
Me he
that
quedado
are
ahora aquí
amicable
porque
for all
quisiera,
the
tenemos
area.
todavía un poco de tiempo para
We have
abrir
still
el panel
some time to
con
open
una primera
the
pregunta.
panel
La doctora
with the
Norton
first
comentó en
question.
su
Dr.
presentación de
Norton
ahora
said
la
in the
importancia
presentation
de la implementación
the importance
de
of the
la perspectiva de género en
implementation
las políticas de
of
salud.
gender
Pero esa es una
perspective
tarea
in
sumamente
health
complicada.
policies. But this is a
El
very
hacer
complicated
investigación,
task.
el generar
To
evidencia
make
es
a research
pues, la base para que las políticas
in
tengan
this
éxito.
sense
Sin
is the
embargo,
base
la
for
transferencia de
success in
conocimiento
policies,
sigue
but
siendo muy
transference of
complicada
knowledge
y
is
ya nos lo
very
presentaron en los
complex.
primeros resultados del proyecto cómo
And
se va
it has been
diluyendo y en
presented
realidad
in the
se
first part
pierde
of the project.
finalmente dentro de las políticas y programas esta vulnerabilidad particular relacionada con
There
el género.
is a great
Y por eso me
vulnerability related to
permitiría
gender,
ahora
and
abrir el
that's
panel
why
para que
I
nuestros participantes nos den una
open the
opinión de
panel so that
cómo
our
priorizar
participants can give
desde
their
la
opinion on
perspectiva
how
de la
to
investigación, cómo hacer esa
prioritize
transferencia
from the
para que se
investigation
priorice
perspective,
la perspectiva de género
and
en
what
las
is the
políticas
most
de salud.
important thing
Me gustaría
to
escuchar
have
primero
this
a
gender
los investigadores que están
a point
en
of view,
en
this
esta
gender
tarea. ¿Qué
perspective.
opinan? ¿Cómo
What do you
establecer
think?
esta
How should
priorización
we
desde su punto de
establish
vista que
this
se tendría que hacer?
prioritization?
Edson, Manuel, ¿quiere primero?
Muchísimas gracias,
Manuel,
doctora Reyes.
do you want to
Es una
go
pregunta muy
first?
importante
Well, this is a
porque
very important
para poder
question.
movilizar la
In
acción
order
política, para que en efecto se
to
considere que hay que hacer algo desde la perspectiva de
impact
género, en nuestra opinión, lo primero que tenemos que hacer es
political
visibilizar estas
fields
desigualdades,
and
¿no?
make
Y
them
estas
understand that we have to do
desigualdades yendo un
something,
poco más
we
allá de
have
lo que hemos visto,
to
no
go
solo en el
beyond.
tema reproductivo,
Not
no
only
solo
talk
en el
about
tema de la
reproduction,
vulnerabilidad,
not only
a
vulnerability,
temas de violencia,
not only
sino también en
violence,
materia de las
but
grandes
also
desigualdades
the
laborales,
great
económicas que se abren
inequities
cuando
that
nosotros
are
metemos variables como
against
el
women
padecer una enfermedad
when we
crónica.
talk about
En México el
variables, for
panorama de las enfermedades
example,
crónicas es muy dramático
illnesses.
y cuando lo combinamos
Mexico
con género,
and Canada
lo que
are
hacemos
very
generalmente
dramatic
es
cases.
invisibilizarlo, no nos damos
And
cuenta,
when we
pensamos que
face
ante una
this
necesidad de salud
gender gender topic, we minimize it. We say that we have the same opportunities, and the results of this study tell us the opposite. This is not the case. And this is also the case in labor and social rights. When the leader of a household is a woman, the risks and the challenges grow. So we have to make a very in-depth analysis and to make an analytical study, because we have to point out which are the differences and the disadvantages that women have in the work, economically wise, at home. So we have to extend our point of view. Thank you, Doctor.
Complementar un poco la
respuesta
de Emanuel.
To supplement it.
Pensaría, digamos, es una pregunta bastante compleja y pudiese dar
This is a complex
trabajar
question.
en varios seminarios y de repente no nos ponemos de acuerdo incluso. Pero
I have been asked in several seminars.
En lo esencial de lo que significa el
But
género,
we have to
cuando
think
uno aborda
on
problemas
the
de salud.
essential
El
things.
género, recordemos todos
Gender,
que
we have
no es
to
otra cosa más
remember,
que una construcción social que permite la reproducción de disparidades en el poder, disparidades sociales, la reproducción de asimetrías del poder. En sí mismo el género es un mecanismo que posibilita la consolidación de estructuras de desigualdad. Estas estructuras son
structures are
pero no son
modifiable.
modificables solamente desde un ámbito. Es
But not
importante
only
pensar
in a
en
special
que el
sector.
trabajo del género y su vínculo con
Gender
los
work
aspectos sociales
and the link with the social
depende
aspects
de la participación de múltiples sectores.
depends on
El sector educativo,
several sectors.
el
Education,
sector de la
for
sociedad
example,
civil, el sector
social
gubernamental, la
society,
academia. En este sentido,
academy,
consideramos que es importante al
politics,
menos
and in this
centrarse
sense,
en algunos
we
aspectos
consider that we have to
la
focus
amplificación de
ourselves
las
in
capacidades
central
técnicas
things.
por parte
We
de los
have
tomadores
to
de asesores,
amplify the
hacedores de la
technical
política en materia de género. La coordinación
coordination,
y el logro de sinergias con los diferentes
synergies
actores
with the
en sociedad.
different
No
players
solamente
in
es una
society
tarea de
is not only
gobierno, del Estado, sino
a
también es una tarea
governmental
de todos
task.
nosotros, en realidad.
We all
El rol
have to
muy importante de la
participate.
academia como para
The
o como
academy
aquel
role
generador de
is very
conocimiento
important.
que
They
sea
generate
tangible,
knowledge,
útil,
tangible,
orientador, informativo
useful,
de las políticas
oriented
públicas. Y lo
to
que
public
parece ser
policies.
algo obvio, pero
It
la
sounds
inversión,
obvious,
but
but
financiamiento
investment and
sin
financing
recursos, o
without
más bien, la prioridad sin
resources
asignar recursos,
or
al final del día
priority
queda solamente
without
en el
allocating
Es
is
importante
only,
también, que
it's a
nuestras
shallow thing.
autoridades, los entes
Our
participantes
authorities
este
have
tipo
to
de
participate
investigaciones busquen que se
and
consoliden
look
mecanismos
for
de
opportunities to
asignación
consolidate a
financiera para el
mechanism
logro de
for financial
investigaciones como estas,
allowances
o incluso
for
modificar
this
la
kind of
agenda en materia de
investigations,
política
maybe
pública
modify
con enfoque de
the
género.
agenda
Esto implicaría
in the
algo tan
whole
sencillo como
political
reportar datos
sector
distinguiendo
with
por hombres y
gender
mujeres.
perspective,
Tener un tablero de
distinguishing the
control para
difference
poder
between
nosotros
men and women,
monitorear los
having
logros y hacer
a
más evidente las desigualdades
dashboard
sociales.
to make these
Entonces, esos son algunos
differences
elementos que
evident. These are
consideramos
some of the
relevantes
elements
para
that
la
are
introducción
relevant
de la
to
perspectiva de género
introduce
en
gender
materia de política pública y
perspective
salud.
in the
Muchas
political
gracias
and
por
health
observar.
sectors.
Doctora Carla Báez, su opinión al
Doctora
respecto, por favor.
Carla Báez, your opinion?
Bueno, ya, sí, sí, no voy a mencionar algo adicional con los que me empezaron, pero simplemente yo creo que para empezar, bueno, mucho de pena que tengamos
I think that it is important to understand that we have to have a feminine focus and go beyond maternity, go beyond reproduction, go beyond violence, and understand that women are subject to certain other vulnerabilities, certain other differences that have to do with illness, that have to do with households, that have to do with work, that have to do with their role in society and how they are treated in society. And of course, we have to give clear information to the researchers so that they can guide and target their investigations to the proper subjects and topics. I think that this is the first research that has been done in this regard, but we would like to conduct many other studies that are focused and centered on this thing, because we know that most of our population are women. We know that the percentage is more than 51%, and we have to focus our attention in all these differences to understand the differences that there are. We have to focus in meeting the needs of this sector of the population.
Muchas gracias, doctora Carla Báez.
Thank you, Doctora Baez. And to close this question round, I would like the opinion of Dr. Norton. From a global perspective, what do you consider that is the most important challenge to establish health public policies with gender perspective?
I'm going to have to ask Emmanuel if he can translate for
Yo
me.
creo que le tienen que preguntar a Emmanuel esa pregunta.
I'd like to tell you in English, from the global perspective,
Desde el punto de vista global, ¿cuál es la parte más importante para implementar políticas públicas desde el punto de vista de perspectiva de género?
I think it is really important to,
Creo que es,
as I've tried to do today, firstly show that we've got to move from thinking about women's health as just being women-specific health conditions to recognizing that conditions like non-communicable diseases are important for men and women, but there are differences, and we need the data. We need to show people that when we produce data, that data give us some very important information that can influence prevention and treatment. So I think it is the work that Emmanuel and the team are doing is so essential to be able to share it with the government of Mexico, to share it with colleagues elsewhere in Latin America, to recognize that this sort of information is essential if we're going to really address the problems of non-communicable diseases in women as well as men.
Thank you very much, Dr. Norton. Bueno, pues para cerrar el panel.
Now, to close the panel, I would like to make a reflection based on the comments of our panelists. Dr. Norton is talking about the information systems, that it is a true challenge. In Mexico, we have a way to go. We also need to have complete information to all the corners of the country. That is our challenge, and we cannot neglect the importance of the panelists regarding the need of a better cross-functional work. Governance is very important to approach this problem. How to achieve the joint collaboration of all the players to give relevance to gender perspective. This is a very important job. And of course, it has the responsibility of the health sector. The health sector has to invite all of the other sectors to work in the social aspect, in the political aspect, in the social aspect. And I would also like to say that not only cross-functional work is important, we also have to think in the population. Women and men have to feel empowered to participate in health policies. They have to be inclusive. We have vertical health policies where the participation of population is only the reception of actions. They only receive the actions. But it is important to consider this participation, the differentiated national, state, municipal state, because policy is still a challenge there, and we have to participate from our roles, our expertise, our points of view. We have to make progress in this sense. Thank you very much. Thank you, George Institute. Doctor, thank you very much. And with this, we'll close the panel.
Agradecemos a nuestros panelistas.
We thank our panelists, and now we will have a 13-minute break. The next panel is mental health post-pandemic.
Buenos días, Elena. Good morning.
Okay, testing, testing. This is the English channel. Testing, can you hear me? This is the English channel. Hello? Good morning. 1, 2, 3, 1, 2, 3. This is an English test. Okay? Ahora el español. Pero esto, ¿lo prendo también? No. Hello, this is the English channel. 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. This is the English channel. We are making a test. This is the English channel.
Si estás hablando con ella directamente cara a cara, pero ya a través del se distorsiona todo, no suena nada. ¿Cómo lo entendiste? Apagamos.
This is an English test. 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. Estaba en español, porque te acuerdas que lo cambiamos al español porque estaba yo hablando en español. Ahorita estoy.
¿Este micrófono dónde va? ¿Cuál va a
English. This is the English channel. This is a test. This is a test for interpretation. This is the English channel. 1, 2, 3, 1, 2, 3.
Buenos días. Gracias a las personas que nos acompañan en el Museo Papalote.
Good morning.
A partir
to
de
you
este
all
momento,
in the
los
museum.
paneles son virtuales, pero están invitados a
From
pasar a
now
la
on,
sala para ver el
panels
siguiente.
are virtually, but
Bienvenidos
you
sean
are
todos.
invited to come to the room and listen to the discussion. Welcome you all.
The translation, please. Entonces, pues bueno, Ali, yo creo que 5, 4, 3, te van a meter a cámara y ya empezamos. Listo.
Perfecto, pues muy buenos días a todos, buenas
Good
tardes.
morning to you all, or good afternoon. There are people connected all around the world. My name is Gerardo Ruiz. I'm Senior Director for Communications and Strategic Communication. It's a pleasure for me to moderate this panel with such an interesting and important subject. We represent the different national agencies in the OECD. We are going to talk about the invisible next pandemic, which is the mental or psychological part. And we're going to talk about what are the things that we can do to face what is happening. Mental health, and you know, has to win some battles. There are some stigmas that are challenging, and it's very important for me to talk about this. Amif, thank you very much for your collaborative strategy during all these years. Thank you for choosing this subject, the mental health. This is
para MIF del 2022. Y vamos a empezar. Bueno, algunos
we are going to start with some figures that will be a guidance for our conversation. There has been an increase of 25% of depression and anxiety in the world based on the dates where the pandemic started. And the attention devoted to health has not translated into a broadening of quality that adjusts to the needs that we have in the day-to-day life. The international sector representing our organization before the OECD, Organization and Development, is a great ally in this battle. So what do we want to do? Number one, what's the current landscape of society and what's happening with the pandemic? Because now there are new challenges that are adding up to what we already had before the pandemic. So we together would like to identify and spotlight which are the strategies that will be focused on controlling the different age groups that we are going to manage. And I know that you all panelists have to deal with. So let's start. I would like to pose a question for each of you, and I'm going to be kind of strict with the time. We will start with María Medina Mora of the psychology school in the UNAM. Hi, doctor. I hope my question is not that difficult, but after what happened in the last 2 years, is there something that has changed in the shape, what we call the stakeholders, how they see the mental health? And if it is so, how can we take advantage of all these changes to optimize prevention and to improve mental health? You have only 4 minutes, and I will interrupt you after this time has elapsed.
Creo que está todavía en mute.
I think you're muted, doctor. One of my first comments is that there has been much more recognition of the mental health, of the mental illness. There are some stigmas, but nowadays we have recognized it as something that can happen to everybody. In the past, it was limited to a certain group of people. Now it is more collective. Something else that another battle that we have won is that technology can help us. Online appointments for mental health is important. In the mental health and psychology school, we've worked a lot. Starting in March 2020 with the pandemic, we started working. But the great challenge that we have not talked about is how to reorganize drugs prescription so that this treatment has a methodological and organized system in pharmacies and drugstores. There has been great interest. Before the pandemic, it was important to change our mindset, trying to collect and to bring together many different tools to support and get together these treatments in order to give service to the community, not in hospitals, because hospitals in the third level with ambulatory appointments are closed. That was not very good. But there was a reform to the health system because we have an expenditure of 80% in psychiatric hospitals. And although the first level grew, there was 50% were out of the third level. And it is not considered a chronic disease. It is only considered an acute disease. But I think it has been recognized differently. And now with this new law, without creating a specific space in hospitals, we have many more people that is sick, that is ill with these ailments in prisons and in the streets. Thank you, Doctora Medina. A follow-up question. How could we advocate so that budget to treat this kind of illness be increased? Do you have any ideas? And I ask you because from our platform with other governments, we have insisted on linking interpretation results not as an expenditure, but to see it together with the link of social impact, of the economic positive impact. Do you have any other tip?
Creo que se ha avanzado mucho en información.
I think that information is crucial. Budget has increased. 2% is what we use. It is 8 times less than the burden of the disease, and the costs are high. We have evidence of the things that we can do, and these things include a very important thing, how to use better the small budget that we have. And how would we do that? Well, using all the resources that we have. Human resources, we have very few psychiatrists, and they are in the big cities. But in Chiapas, for example, we only have 1% per 100,000 inhabitants, while in Mexico City we have 30%. So we have to review these programs in the first level. The advantage is that diabetes, for example, went to the first level. So we have already an example of one of these diseases treated in the first level. So it gives a role model for the psychiatric illnesses. And we know the high cost of not treating these illnesses. Very high. Working places are a good option because going back to work face to face has been very difficult. Also schools were closed for 2 years. It was one of the few countries that did this. Children lost a lot. Work for women at home increased. There's a lot of evidence that we have difficult times ahead, and the cost for children has to be minimized. We are the country with more orphans in number. We are the third place in number, but in denomination, the third place. And these children have suffered a lot. The knowledge loss they've undergone has been very high. There are many vulnerable populations, but children is an important one. So which could be a tip? Working places have to have mental health aides. We have to understand that face-to-face treatment is not 100% necessary, and we have to fight a battle so that more budget is allocated. I'm not very optimistic because the new law doesn't have an increase in budget. But nevertheless, we have to make as many efforts as we can to assume responsibility. I agree with you, and as the OCED said, there's a lot to discuss. And it is important that we can start using the numbers, the data, and all the output that we have. Comorbidities for diabetes and depression are many, and we have to go into further detail in this regard. I don't know if we'll have time to discuss this. Now we'll go to Jacqueline Cortez. She is from the Psychiatric Association. It's a pleasure to have you with us. It's like a little bit of a follow-up on what I asked Doctora Moran. What is the potential of this Zoom technology? When we talk about telemedicine, what's the potential that this tool has, not only to correct, but also to monitor and identify in the early stages problems, opportunities that are linked with mental health?
Visto la profesión que usted representa, ¿de qué forma podemos cuidar a los que cuidan?
Since you are in that privileged role, how can we take care of the people that we have to take care of? I'm very happy to be here. And I agree with Doctora Medina Mora. One of the positive things that this pandemic has left is that people look at mental health in a more dignified way. And not also them, but also other kind of doctors. Because doctors sometimes we are educated to not sleeping, to not eating, to very hard schedules. But I think that we have to also take care of our emotions. We have to take care of ourselves. And when Doctora Medina Mora was my boss, on March 21st, the pandemic started, and we rolled out this new way of working on the 26th. The new model that was implemented here, based on the UNAM, was good to use it in a campaign. The medicine school and the Mexican Psychiatric Association work together with, we also take care of ourselves. That's the name of the campaign. And it consists on giving emotional support to people with COVID. This was very relevant, very important, because all the doctors, rural doctors, dentists, nurses, specialists, we couldn't treat properly a patient if we are not stable at an emotional and social level. So some of the advantages that this pandemic gave us is that doctors could recognize that we sometimes dehumanize and not accepting those levels that were given to us, that we were heroes and that we could do everything. When your body gets sick, you can, it is visible, but when your emotions are sick, it's not that visible. We have to assume that sometimes diabetes, consumption of drugs are or go hand in hand with depression and anxiety. I remember when we saw that hospitals were totally full, seeing a lot of people dying, even colleagues, was a total and constant impact for us. We also had losses in our family. And with this campaign, members of doctors' family were also treated. This campaign has a great scope. And one of the good things between the AMIV, Mexican Psychiatric Association, and the medical school working together, we have a platform for tele appointments to give more psychological support for whoever needed. And if we continue with these challenges, we have to rely on electronic media and several other cross-functional sectors. We have to pay attention on prescriptions, and we have to be very careful with the indications to treat the different ailments. Some other aspects that have great potential is that, as Dr. Medina Mora said, is that we are very few psychiatrists, and child psychiatrists are even less. So, applause that we have put in place here at UNAM is the cross-functional approach. We work hand in hand with the psychology school, psychiatry school, but also specialists for children. And with this, we may identify certain conditions, and we define the psychotherapy that must be used to treat this illness. Drugs are important to slow down symptomatology, but therapy is good to help people face their day-to-day life. We have to learn how to use all these new technologies to face the challenges that we have encountered during the last years. Thank you for your intervention, Jacqueline. We need alliances, just as the ones you mentioned, and for all the problems that we have to face in the future. These kind of services are very much needed among the population, and also they are more frequently offered. Now we are going to change language.
You're the general manager of the VR and mental health solutions at Biogen Digital. And I wanted to maybe ask you a question regarding what are the strengths of the digital solutions that a company like Biogen can bring when it comes, again, to preventing and tackling mental health? And then, as I was sort of foreshadowing just a couple of seconds ago, what are the, what do you need in terms of public policy support or public policy initiatives to be able to implement them at an appropriate scale? So the floor is yours, and great to have you with us.
Yes, thank you so much, Ali. But before we switch to English, because I can speak a little bit of Spanish, please allow me to say a few words. So, first of all, muchas gracias por la invitación. Estoy muy feliz.
Thank you very much for the invitation. I'm very happy and honored to participate in today's conference. Our mental health is very important, and it is a subject that requires attention and changes in several levels. Today, I would like to share what I have learned working in this subject, and more concrete, how technologies would help solve some problems.
Most of it correctly. And now I will go to the main question. So, Ali, I have been working on the space of digital health for the past 10 years. Even when digital health was not even a terminology that people could understand what we mean when we're talking about digital health. And I am particularly passionate about mental health. The reason is because I do not see mental health as a separate issue, and it is often neglected. There is, I believe that because I understand a little bit of Spanish, I think that Dr. Medina talked about the stigma that it is associated with this condition. So patients do not talk openly about it, and therefore they do not seek for help when it is needed. In addition with that, people who suffer from mental health issues, they feel very guilty, they feel like they're a burden to their family, and because of that, they often isolate, and that doesn't help. But emotional health cannot be seen as different as any other problem. Like, people openly talk about diabetes, and it's a thing to share openly with everybody. But when it comes and somebody suffers from depression, they tend to suffer alone. In addition to that, there are differences because of gender. Typically, women tend to be a lot more open about mental health compared to men. That's why we see suicide rates, specifically for men in ages in the between 44 and 49 skyrocketing. There are cultural differences. In specific countries, it's a big taboo to talk openly about mental health, where in other countries, they tend to be a lot more aware. What I have learned from working with different technologies, the first learning is that technologies is not a panacea, and they're not going to solve the mental health issue, because the human touch is very, very important, specifically for this particular patient population that requires specific handling. However, technologies, they do have the opportunity to bridge the gaps in specific areas. So, for example, there is a big debate whereas pharmacological treatment should be a first-line therapy or a second-line therapy. For certain, areas such as, I will say, for mild depression, maybe the first line should be talk to your therapist first before we introduce a patient to medication, specifically because the medication available to us today, they take a lot of time to really start seeing some effects, and that creates a lot of problems for adherence from the patient. And then there is they're losing their hope, and then they enter this vicious cycle of trial and error of new medication. We also know that there is a lot of side effects with the current medication. So there is this opportunity of how can we keep close connection to the patient after the patient leaves the clinician's office, because we have to also be realistic here. The clinicians can see the patient for 15-20 minutes, and that's it. Then they go home, and then they suffer alone, and depression is with them every step of the way. So if technology, for example, and Dr. Cortes talked about it, and I think that there is a whole initiative and a campaign that is happening in Mexico right now about telemedicine. Telemedicine, and I can tell you the learnings from US, it has been a concept that it was alive, and it made sense, and it was responding to an unmet need since 10 years ago. It took the pandemic to make people realize that telemedicine can be used, and one of the main reasons, it was the regulatory challenges. Simply when we left with no other choice, there was no more questions about adoption from the clinician's perspective and the patient's perspective, and suddenly all the regulatory challenges were lifted as well to make treatment available to those who were needed. I had the chance to talk with psychiatrists in US, and they were telling me how happy they were and how actually they were seeing their patients not canceling the follow-up visits, because now they had the convenience of connecting with the patients, with the clinicians through the screen. So telemedicine, I believe that it is one of the critical core elements that we can introduce today with, and this is where the regulation and the government plays a very specific role to reinforce and put the regulations in place to allow that to happen. The other thing that I have also learned from talking to both patients and clinicians is the power of a care coordination platform. And what I mean by that, the patient feels isolated, the patient feels that they need support more than any other patient population throughout their journey. So they need to be able to have, through a technology, to create their own circle of trust, and include in that circle of trust the people that they want. Because again, because of the guilt and the stigma, patients need to be empowered to control that circle of trust. That circle of trust could include the psychiatrist, it could include the therapist, it could include a certain member from a family, not always, but it could include a friend. And these people, they become their circle of trust and continuous motivation throughout the journey. Then there is this whole new area that I understand that it is still evolving, which could include continuous collection of data. And that could involve, areas such as EPROs, such as a PHQ-9, which is something that clinicians understand and they are trained, but they could involve some other very, very important data sources. That data can be collected passively. And that's a key point here, because when we're dealing with a patient who is lacking motivation, we cannot expect, even if we create the best platform in the world, the best mobile application out there for that patient to stay connected with that platform. However, technology, it gives you the opportunity to collect some data in a passive way. For example, we all know that one of the major things that is being disturbed when somebody has depression is sleep. So interruptions in your sleep patterns can tell you a lot about the patient's status. So imagine a simple way, and actually patients, they have their own tracking systems because they want to feel empowered. So they're trying to find their own ways about how they can keep track of their health. If we could include some of these additional sources in that overall platform. So these are, some of the ideas that I would like to share with you, because on the other hand, as we are thinking about how we can make the biggest difference and how we can keep that pragmatic, I do believe that there are two main things. Mental health needs to be recognized on a national government level as a problem, and it needs to start with education as early as kindergarten. It's okay to talk about your feelings, and it's okay not to feel okay, but it needs to be a change in the mindset where people feel comfortable about that. And we're talking right now about mindfulness and meditation. Mindfulness and meditation is not something that somebody should realize the power of it when you are dealing with a crisis, because then it might be too late and it requires a lot of extra effort. Meditation is something that should be implemented even in the elementary. I mean, why don't we teach our kids 5 minutes to calm the mind and feel comfortable with these, sometimes intrusive thoughts or bad thoughts or sad thoughts. But the second main point that I would like to say is that we also have to be pragmatic about how we are thinking about change, because we say that, yes, we want to change the thinking about mental health, and we can have these big goals about how we can prevent suicide. I think all these are great and inspirational goals, but we have to keep it on a pragmatic level. And what I mean by that, small changes can have a compound effect. And that is where success needs to be measured. We should not try to shoot for the stars. We should try to shoot for like 1% incremental change, and then keep adding on it.
I totally agree, and thank you, Georgia. I think that one of the, if I were to summarize, one thing you mentioned that really struck me is that there has been progress in terms of reducing stigma diagnosis, but maybe where we still have progress to make is reducing stigma regarding the solutions that are available. So I'm sure it's something that we can discuss going forward. And as you were mentioning, some of the multi-stakeholder efforts that are needed, it's a perfect segue into our next speaker, which is somebody that I know quite well from collaboration for a number of years. Very pleased to have with us Mark Pearson. You're the Deputy Director of the Employment, Labor and Social Affairs Directorate of the OECD. And the question that I have for you is, what does the OECD recommend? You saw that Dr. Medina Mora referred to your data. but what does the OECD recommend governments should implement when it comes to mental health? I know that you've been lately even more active on it. So what are some of the gaps that need to be filled? What are some of the experiences that we should continue to scale up? And the floor is yours.
Wonderful, great to see you, Ali. You know, and as ever on these sorts of events, I'm just in awe at the other panelists who do such fantastic work. I feel a bit of a fraud because I'm not a doctor, I'm not a psychologist, psychiatrist, I'm an economist. And so, you know, me talking about mental health when you're all doing such amazing things seems somehow wrong of me. But of course, yes, my angle is really to try and look at what governments are doing, what's going well and what's going right in their policies. And Ali, you asked me about the gaps that are out there that we should try and fill. I think there's three. I mean, there's loads of gaps I could highlight. And from a policy side, I'm going to focus on three. The first one, guess what? It's money. You know, we've been working at the OECD, looking at mental health from different angles for 20 odd years to try and understand what's the best thing that works, what countries should be doing, given that we know that 1 in 5 people, up to 1 in 5 people at a moment in time could be having some sort of mental health problem, a huge, huge number. And of course, if you've got some sort of mental health issue that needs to be addressed, you're not going to learn properly. You're not going to work properly. You're not going to participate in society properly. Everything is affected. And that makes a huge impact on people's well-being, but also on our economies as well. And that's when we add all the impacts of not learning properly, not working properly. You know, we're talking about maybe 4% of GDP due to poor mental health. At a huge, huge amount. You know, we've tried to recently, we've come up with a benchmark to try and measure how well countries are doing in different dimensions in looking at mental health, looking at prevention, accessible, high quality, person-centered services, integrated multi-sectoral approach, strong governments and leadership, innovation, all those different measures. And looked at it across all the different 38 OECD countries to see who's doing well and who's doing badly. And sure, I could talk about the different dimensions, about who's doing slightly better and who's doing slightly worse. But the central message that I think comes out of that is gaps. It's just countries not doing well. No country doing really well in all these different areas. And you know, even the best performing OECD countries, we're still talking about 30% of the population saying either they or a member of their family has struggled to receive appropriate mental health services in the last year. It's a huge number. I mean, that's something we would never tolerate for cancer, for cardiovascular disease. You know, you go through the other areas and we would not tolerate it. And yet for mental health, that's just the situation. So look, money, I'm afraid, is the first gap. Second gap, and I will be briefer, I promise, Ali. Second gap is data, actually. I mean, although I've quoted some numbers, and yes, I'm a data geek, I love quoting lots of numbers about what's going on. We know so little about mental health, about who's affected and what their particular problems are. It actually did get a little bit better during the COVID pandemic. A few countries started monitoring mental health on a much more regular basis, on a population basis, much better than they did before. And that's why we can start saying things, you know, like you already quoted, Ali, the big increase in depression and anxiety due to COVID. I mean, and we, even for some people, some countries, we can say which population groups are most affected. You know, young people, even higher than the numbers you talked about, Ali. I mean, it can be up to 50% increases in the number of people, young people reporting depression and anxiety. But it's still pretty poor, our evidence base, and we really do need to do much better. That's one of the areas that we're working on at the OECD. We've got something called the patient reported indicator surveys that we're setting up, which will look at various chronic diseases, one of which will be mental health, when we look at how people are interacting with the health system, what sorts of treatments, what sorts of advice they're being given, so that we can actually assess across countries what countries are actually doing for people in different circumstances and try and see if it makes a difference. But generally, I think that's a massive gap. We just don't know enough about mental health or about mental health policies and about how they're influencing people's well-being. And last gap I'm just going to mention, actually it's already come up several times today, thank goodness. It is on a gap in integrated policy making, because, you know, frankly, when we started work at the OECD 20 years ago, it was quite focused on health systems, and it was for many years very, very frustrating trying to make progress. And frankly, I don't think we will make huge progress if we continue to try and focus just on what health systems can do. People in health systems focus on acute diseases. They focus on what kills people, getting them to focus on things which just affect people's lives. It's a real uphill battle. It is far easier for me today, if I want to do a ministerial discussion on mental health, to ring up ministers of labour and get them to talk about the impact of poor mental health on the labour market than it is for me to ring up health ministers and say, would you mind talking about what health systems can do? And I think that's the way in. It is to talk about the wider effects of mental health on the goals of government, on employment, on incomes, on well-being, on education, and you'll get much more buy-in from these other sectors rather than from just focusing on health. And so pulling together all those sectors in an integrated way, and some countries are doing pretty well. I think that's well worth focusing our attention. So that's my third gap. There you go. Back to you.
Well, thank you, Mark. And I think you hit the nail on its head with this, in particular, this last point about the integrated policy responses, to the point that I want to ask all four of you a follow-up question on that, because, first of all, it's something that it rings a bell for us as a global business community. It's also something that we call for. We call for more dialogue among the health, employment, and let's say even finance ministries and even ministers. Maybe a question to any of the four of you who are with us, and let's see who my first victim will be. What are good ideas to get into this integrated policy thinking and maybe even action? ¿Cuáles serían algunas ideas que podríamos implementar para integrar más este tipo de estrategias de salud mental a nivel interagencia entre varios
What are some of the ideas that we could use to make it, to cut across all the different ministries and secretariats? Well, I think that one of the ways to impact the different levels is to think of it as a teamwork, starting with the basic levels that has to do with mental health, prevention, psychiatric disorders. We have to start with elementary, high school, prep school. Part of the obstacles are the lack of knowledge, so that once we have it, we can decide on the best solutions related to mental health.
Muy sustantivo y al mismo tiempo muy breve. Genial. Marilena.
Thank you. You were very subtractive and very elemental, very good. Maria Elena, well, in Mexico, we should integrate mental health in the wholesome health system. This is something important, but it is not enough. All the investment that has been done has been painful, not only in Mexico, but all around the world. And we've made some researches, and we know that it's been all around. So what should we do? I would say working more on the preventive part. Research tells us that prevention is good for depression, not only identifying symptoms, but try to follow several conducts that would reduce the risk of suffering some ailments. We should work with the community, work with all the resources the community have to offer. I was very impressed by with George said. I don't know if it should be in the first level, the prescription. Yes, I know that the prescription is very sensitive, but I think it could be in the first level. The therapy would be in the first level and medication in the second level. Because sometimes there are very soft or light cases that go growing without any treatment. Everywhere suicide was decreasing, and that the COVID was not increasing it or was not a cause to increase it. But what happened in Latin America? In Latin America, since it was not monitored or it started low, it increased more, especially in young people. So we have to take advantage of this integration with the community, the social, the clinicians, with healthcare. But not only in the care, in the healthcare system, but also at work. Also, employers must pay attention because they have great economic losses sometimes. It's very high, the amount of money they lose when they do not pay attention to these things. So the mental health should be included everywhere. When you a publication from Lancet before the pandemic said that within all the sustainable development goals, in 15 out of 17, women were key. They were affected by their care mission, loss of work, and this made us think that we have to pay attention to women when we talk about mental health. But in this specific case, we also have to pay attention to men because we get sick, men and women alike, but in a different way. So in violent cases, it is because women are more prone to become victims and men become more violent. And this becomes a vicious circle.
Incorporando a todos los sectores que
So
están
we have to
involucrados
include all
y
the
con un
sectors,
principio que sea siempre incorporar la salud mental en los
and
programas,
the
¿no?
main objective has to
Creo que
be
eso
including mental
podría
health
ayudar.
Muchas gracias, Marilena.
in all
Back
the
to
different
Georgia,
pathways of
you were
life.
mentioning before
Going
multi-stakeholder
back
efforts and
to
also the
Georgia.
importance of early education, which, by the way, reminds me of a campaign that we did. It was over 10 years ago that we called the "Do You Mind" campaign, and one of the pillars actually insisted on education early on. So I hope that we've made progress since. But is there anything else that comes to mind when it comes to fostering this integrated policy thinking and responses that you would like to share?
Actually, there's a couple of things that come to my mind, Ali, and I wanted to build up a little bit upon what Mark said, which I believe that maybe, and this is my humble opinion, but I believe that the key to really pressure for that integration of different multiple stakeholders to battle together the issue of mental health is the economic implications of mental health being untreated. So when a nation realizes that if the mental health implications, the productivity losses, the more lengthy time that a person requires who's in a poor mental health to recover from any kind of operation, if we put all these things together, even for those who, let's say, they're still not understanding the magnitude of the problem, once we put the numbers there about what is going to happen to our world in 10 years if we do not take care of the mental health now, I think that it will create a sense of urgency. And the other part that I wanted to tell you, which is related to your question, I do believe that because I'm originally from Greece, and I have been living in US for the past 18 years. So I have in my mind the two big contrasts in the healthcare system. In the US, it's going to be very difficult for that integration of stakeholders and try to get alignment for the policies. However, in smaller countries that they may have more centralized healthcare system, I do believe that there is a higher chances for success of the stakeholders getting together and trying to tackle the issue in multiple levels. I think that Dr. Mendina talked about salud total, which is practically, and I didn't understand specifically, so I'm sorry if I didn't understand that, but it's all about addressing the total well-being. And I think that's what she was referring. So salud total is the main issue that we all need to come together. And that's why salud total, it is about salud, it's not about disease, which talks about the whole prevention. And that's why this discussion needs to happen at the very early stages. And like everything else, we have the opportunity now with technology to use multi-channel engagement with different stakeholders. These young kids right now, that they are suffering, and the whole pandemic intensified the problem with anxiety. They are on Instagram right now, they're using TikTok, they're trying to find solutions themselves. Why a government cannot use a coordinated effort who've tried to meet their people where they are. So for young people, you create a campaign where you can find them. For older people, you create a campaign maybe in Facebook, because this is where you can find them. Maybe for clinicians, you make multiple efforts to understand, for example, why they should not be scared or skeptical about using digital solutions. And
I agree. And Georgia, I'm told we have 2 minutes, and so I want to take one last question to the group, and I'll have Mark go first, not to feel the pressure. But when I organize or when I'm invited to moderate these panels, I always like to ask, besides sharing the state of play, where can we tangibly go? How could, what would success look like to each of you in 2 years? If what we just shared today, if we can move the needle and go somewhere, what would be 1 or 2 things that in 1 or 2 years' time, you would say, all right, if we've made this in 2 years' time, we've made a little bit of progress. Going back a little bit to what you mentioned, Georgia, about doing incremental changes. So Mark, over to you.
Yeah, I think that's a very good way of looking at it. And I actually very much echoed what Georgia said about making small steps, small progress, because, I would love to sit here and be able to say, we need to make this the international priority to tackle mental health. It is, as you say, Ali, absolutely the hidden crisis. The numbers are appalling, but being realistic, we've got COVID left over, we've got Ukraine on the way, with the implications going to go on forever. We've got massive public debt hanging over our health systems. We've got antimicrobial resistant vaccines, all sorts of different things on the agenda. I don't think in the next 2 years we're going to see mental health becoming the #1 priority even in global health discussions. But what we can do is set ourselves up for when eventually the time is right to have those discussions. So what I would really like to see is a concerted effort to get that data to be better, so that when we can get that attention from the prime ministers, from the presidents, so they turn up at the UN or the G20 and have a massive call for action, we can say, this is exactly what you need to do, and we will hold you to account on how much you spend and how much you achieve. So I'd love if we could actually put together an international data initiative over the next couple of years.
Wonderful. Thank you, Martin. Hope we can contribute to that. Jacqueline, do you have tienes algunos 30 segundos para decirnos cómo medirías el éxito de aquí a 2 años?
You have 30 seconds to see how would you measure success in a 2-year time. Regarding suicide, that it is very important. We should pay attention there. Also, gender, the conditions due to the use of substances. These 3 things are very important. And these 3 things are sometimes the base or the pillars for mental health. And we have to do it through the implementation of healthy habits in prevention, but also early identification. Because in some cases, it's a hereditary factor here, and there are many people from the family that have these kind of conditions. And in third place, the cross-functional approach. Now, Maria Elena, 30 seconds. Well, just to supplement what it has already been said, the social determinants in 2 senses. Treatment by itself is not good enough if we live in a violent society with all the things that we have been mentioning: poverty, violence, intolerance, events like this pandemic. If we do not pay attention to these factors, we will not succeed. And on the other hand, we are a country that have only 50% of the population working formally, that only half of the households have water, overpopulated households, deaths of very poor and vulnerable families. If we do not integrate all the different development aspects, we will not be able to face everything that is related to mental health. We have to create confidence. We have to create that, because sometimes people go for an appointment, a medical appointment, and they do not follow the indications. So we should pay attention to that. Regarding COVID, we have learned. We have to be prepared. We have to be informed. We have to be prepared. We have to work on our readiness. Yes, I agree with what you said about resilience and informality.
Also 30 seconds.
Yes, 30
Georgia.
seconds, yes, Ali. So 2 things. So from my perspective, because I'm not a policy person, my focus is on digital technologies and potentially try to find ways to bridge the gaps. I do believe in the next couple of years, the efforts should be focusing on developing these digital technologies, which actually could be a great vehicle for what Mark was saying about data collection. I think that we need that real world data collection, and why not having some of these digital technologies becoming treatment alternatives. But on a more, I would like to say, in a more softer perspective, if you will, I do believe that each one of us has the opportunity to be a change in this world. So unfortunately, depression is, if you ask people around, and I have been in many conferences talking about mental health, so when I ask the question, Do you have somebody in your family that has suffered from that? Do you know a close friend or a family member? You see lots of hands coming up. So what I mean by that, we definitely need these bigger efforts, integrated efforts from multiple stakeholders on a different level. But I do believe in the power of one. And this goes back to incremental changes. So when each one of us sees somebody who's struggling out there, and when a person is struggling for depression, they need all the support in the world. And it might be just a simple motivational words. Sometimes it might be the person that's placing the call to the psychiatrist. Sometimes it's just a friend that takes that person out for a walk. So I do believe that we have the power to make these small changes, and we can change one person's life.
Thank you, Georgia. I think it's a fantastic way to wrap this panel. And muchas gracias otra vez a todos ustedes. Hemos tenido un muy buen mix, como lo acaba de mencionar Georgia, entre
Thank you to you all. We have had a very good mix. We have speakers from the public policy, economics, from the health sector. We have very different backgrounds in our speakers. Thank you very much. We also have a great strategical support from AMIF members in order to hear the corporation's voice in the debates. Have an excellent rest of the day. Enjoy yourselves. Thank you very much.
Gracias. Excelente liderazgo.
Excellent moderation in this panel.
Los invitamos a permanecer para el último panel.
I would invite you to stay here to see our last panel, Efficiencies and Innovation in Cancer Treatment. De 11 a 11:50. Margareta Colangelo. En inglés. Entonces empiezas tú. Luego Cintia Villarreal Garza y Alex Filistemas. No, Cintia en español, luego Alex en inglés, Isabel en español. Uno. Voy al baño rapidísimamente, corriendo.
Adelante. Muy buenos días a todos. Es un gusto estar hoy con ustedes
Good
en
morning
este
to
panel.
you all.
Realmente
I'm
hablando de
happy to
innovación
be here
y hoy
with
un tema
you.
muy importante.
We've been
Cómo
talking about
enfocarnos, qué
innovation,
pensar
and now
específicamente
something very
en materia de
important.
eficiencias e
What
innovación
to
en la
think
atención
about
del cáncer.
efficiencies
Sabemos
and
todos que
innovation
cerrar la
in
brecha de
terms of
acceso a
cancer. We
salud
know
es
that
un reto que
bridging the
tenemos.
gap in terms of
Es un
health
reto que
is
tenemos
a
por
challenge.
y para las
A
mexicanas y los
challenge
mexicanos.
that we
Y un reto en
have
el que
for
tenemos que trabajar todos
Mexicans.
juntos.
We have
Ustedes,
to
yo,
work all
todos
together,
nosotros, todo el sector público, el sector privado,
all of
todos de la mano.
us,
Así que la propuesta hoy
public and
es tener
private
una
sector,
plática
hand in
con personas
hand.
que conocen mucho en la materia, con la visión de México, con la visión de
We
fuera,
have to work
y
with
encontrar maneras de
experts
cómo sumar.
with
Porque México es
domestic
único.
and
Es tu
international
México,
vision.
es mi
Mexico
México,
has to
es nuestro
work
México.
as one.
Queremos un México donde cada vez trabajemos juntos
Mexico
para ir cerrando las brechas de
has to
acceso
work
en materia de
together
salud.
to
Y
bridge
hoy,
the gaps in
específicamente,
terms of
en el
health.
panel que
And
amablemente me invitaron
today,
Cris y Carla a
we
coordinar,
have
me toca hablar sobre cáncer.
to
Para
talk
nosotros en la
about
Fundación Mexicana para
cancer.
la Salud,
For
entendemos
us,
precisamente que
in
cerrar las brechas de
the
acceso en cualquiera de los temas
Mexican
implica tres cosas.
Association for
¿Cómo
Health,
logramos
we
que el personal
understand
de
that
salud
we
esté en
have to
tiempo y
pay
forma?
attention to three
No importa si
things.
es un técnico, una doctora,
How
un enfermero, una enfermera, y que
to
todos
make a
trabajen de manera
doctor
coordinada.
or a
Pero también
nurse or a
que esté la
specialist
infraestructura en
work
tiempo y forma.
coordinately. They have
Estén los
to be
equipos, esté el equipo
ready
diagnóstico
in time
y
of
que esté todo
manner
funcionando
to
para que
have
cuando
the
un médico pida un
equipment, to
estudio,
have the
realmente se pueda
diagnosis
realizar en tiempo y forma.
team.
Y por último, por supuesto que los medicamentos y los dispositivos
Last but not
también estén
least,
disponibles.
the
Si un médico manda un
equipment,
estudio,
the
tenemos el
tools.
resultado,
If a
pero después no
doctor
está el dispositivo,
prescribes
o no está
a
el medicamento,
test, we need
otra
to
vez
have the
fallamos.
drugs, we need to
Fallamos en
have
dar
the
la atención a
medicines,
esa
and we
mexicana
need
o a
to
ese
have the
mexicano.
equipment.
Así
We
que a
fail
nombre de
with the
Eric
service to
Haxaker,
Mexico.
presidente del Consejo de la
So,
Fundación Mexicana
on
para la
behalf
Salud,
of
tenemos el gusto hoy de moderar este panel.
we
Así que
will
permítanme arrancar,
moderate this
y
panel,
tenemos el gusto de tener con
and
nosotros
we
a
will
Margareta
start
Colar.
with
Margareta es
Margareta
CIO de
Colade,
la Alliance for
CIO
Artificial Intelligence in
of the
Health. También nos
Alliance
acompañará
for
la doctora Cintia Villarreal.
in,
Ella es directora de oncología
Artificial
del Centro de Cáncer de Mama
Intelligence.
de TechSalud.
We also
También está con
have the
nosotros
director,
Alex
Cynthia
Filiseevas, que es
Villarreal
presidente de ONCAL
Garza,
Internacional y a la vez
Director
es
of
el director
Oncology
ejecutivo de la Coalición Mundial de
of
Pacientes
the
con Cáncer de México.
Breast
También
Cancer
nos acompaña
Institute.
entre nuestros
Alex
panelistas del día de hoy,
Filiseevas,
nada más y
Chairman
nada
of
menos que
OCAN
la doctora Fernanda
International,
Navarro.
Director
Ella es directora
Executive
regional
of
en
the
Latinoamérica
World
en City
Coalition
Cancer
for
Challenge,
Patients.
así que bienvenidos a todos
Also,
ustedes.
Isabel
Les voy a pedir
Mestres.
primero arrancar a Margareta, que nos
So
dé
I will
primeramente una
start,
primera impresión.
Margaret,
La
to
idea es que
start
hagamos
with the
una
first
ronda donde cada uno de ellos nos
impression.
exprese
I would
su
like
visión
to go
y después
through
hacer
a
algunas preguntas y
whole
respuestas.
round so that
Así
they
que
express their
disfrutemos
point
el
of view
panel
and then
y
make
encontremos
some
una manera de
concrete
construir todos
questions
juntos.
to each of
Por ese
them.
México que es tu México,
Let's
mi
try
México
to
y
place
nuestro
the
México.
building blocks
Y ayudarnos a cerrar
together for
precisamente las brechas de
Mexico,
acceso, hoy
bridging
específicamente
the
en
gaps
cáncer.
that we
Así
have
que adelante Margareta,
in
so it's a
the
pleasure to have
cancer
you today with
subject.
us. So I'm really willing to hear what you have to share with us. So please now help us in explaining what are your visions. Thank you, Margareta.
Thank you, Hector, and thanks for having me on the panel. So, I track AI in healthcare across all diseases and all areas of healthcare. And the biggest impact that we're seeing is using AI to help screen for cancer, diagnose cancer, and help choose the best treatment for the patient. And in the last year, there have been many algorithms that have been cleared by the FDA to use, and they're really increasing the accuracy with which we can diagnose cancer, and then also really personalizing the treatment that we give to cancer patients. And I just have two quick examples. One is using AI in pathology for prostate cancer. And we have an algorithm that was approved about 6 months ago from a company called Page Prostate. And using this algorithm, pathologists can improve their accuracy from 89% to 96%. And that's huge because if they can use this algorithm, then people don't have to have biopsies. That really saves a lot. And the other area is in breast cancer diagnosis. Using an AI algorithm that was developed using deep learning at the University of Hawaii Cancer Center, radiologists can improve their accuracy from 82% to 90%. So they can really, really help women avoid unnecessary biopsies. And I think that the number is we can decrease the number of unnecessary biopsies by 71% if we use AI. So that's just a quick overview, but across all cancers, we're seeing a lot of impact with using AI.
So thanks a lot, Margarita. Quite interesting. And I don't have a doubt. When we use the new technologies in trying to help do the right diagnostic, it's clear, it's critical. It would help us a lot in when you look at our system, when you look at IMSS or ISTE or any of the systems working in Mexico, and also the private practice, it's clear that it could help a lot. It could reduce a lot of costs to the system, and also the precision of knowing exactly what's happening with the patient. So thanks for the examples. And now I would like to hear la doctora Cintia Villarreal. ¿Cómo lo ve el TechSalud, Cintia, y tú personalmente? ¿Cómo ves hoy la materia, el tema de innovación en cáncer? Una primera reflexión, por favor.
Hola, Héctor. Yo les quiero presentar rápidamente unas diapositivas, nada más que no puedo compartir pantalla. No sé si me pueden dar oportunidad. Todavía no puedo. No sé si quieras, en lo que me dan oportunidad de compartir, empecemos con... Todavía no.
Si quieres que presente mientras,
sí.
Alex, ¿te parece? So we'll do the following, Alex. If you want to now to continue while we get the option for Cintia to be able to present. So please, Alex.
Absolutely. Thank you, Hector. And it's such a great pleasure to be here. So thank you for the invitation. So I thought very briefly about Allcan itself. We like to think of Allcan as a think and do tank. And we were originally established in 2016. So it was a coalition of multidisciplinary, like-minded stakeholders, both organizations and individuals. And we've set out on a mission to find solutions to the challenge that we're here to discuss, efficiency, or as we then looked at it as a waste in cancer care as well. And then since then, and now members remain united in our belief that we can do better with the resources that we have available in cancer care for the benefit of cancer patients today, and especially in light of the pandemic, it's increasingly more important. And our strength as well is the international community with over 20 national chapters in addition to Allcan International. And we've recently welcomed the Allcan Mexico as well to the family. So it's a great honor to be here today. And so first of all, as well, it's important to define what we mean by efficiency. From the Allcan perspective, efficient cancer care delivers the best possible health outcomes using all resources available, but with a focus on what really matters to people with cancer and society. And we always stress that efficiency is not a means to cut costs, but that the resources freed up through increased efficiency in the systems should be reinvested to advance innovation or increase system resilience. And so very recently, we've developed Allcan Building Efficiency Blueprint in response to this sort of renewed urgency to build efficiency in cancer care that we see today. And specifically, the objectives of the blueprint were focused on highlighting the key areas of inefficiency from the unique perspective of Allcan's multi-stakeholder composition and the global point of view, and also offer recommendations for local and national adaptation, and showcasing good practices that we also feature quite a lot of those on Allcan Efficiency Hub that come directly from real life examples, real world examples on the Allcan website. And so building efficiency in cancer care from our perspective starts with two essential overarching values, and that being people-centered. So this means aligning all aspects of cancer care and prevention to meet the needs of patients, as well as carers and general public as well, and collaborating with the people affected when we're talking about the decisions affecting them. And then taking a whole systems perspective, so meaning treating each patient's care pathway and the entire cancer system as an integrated whole in a way. And there are significant opportunities that Allcan sees to improve efficiency along each step of the cancer care continuum. So from prevention to early diagnosis and all the way through to treatment supportive and palliative care. And our blueprint takes each of these into account. And I just wanted to touch just on a few in a couple of minutes. And I'm sure the report would be shared with the participants today who are interested to dive into a little bit deeper. And so the 4 dimensions were focused on empowering and partnering with people, so promoting shared decision-making within patient care, for example, through measures to improve communication between healthcare professionals and the patients and their caregivers, or supporting and promoting patients and carers' access to patient organizations and support groups, as well as involving patient representatives in wider aspects as well of the decision making. So another dimension is supporting healthcare professionals and providers. So really focused on planning and enabling, incentivizing multidisciplinary care and ensuring the well-being and safety of the workforce. The third dimension we touch on is particularly important, implementing a data-driven learning system, right? So really data is central to quality and innovation and efficiency to cancer care. And I think Margareta touched on the role of AI in all of this. So using patient relevant data and it should be collected systematically, shared and reported between healthcare providers so we can really overcome any barriers and challenges to fully harnessing this. And lastly, investment in efficient technology. And I think that's a no-brainer. And we really need to strategically and systematically direct the resources towards efficient technologies and practices as well, and exploring things like outcomes-based reimbursement schemes when it comes to access, or implementing specific measures to support adoption of innovation in practice itself. So in conclusion, building efficiency in cancer care should be a top priority, but via the whole systems-wide changes. So we really need to look at it holistically. And all of these actions should also be geared towards as a joint effort in consultation and collaboration with all stakeholders. And we have a range of them here today, so I'm very much looking to the discussion.
So thanks, Alex. It's quite interesting. Y sin duda, esta visión de entender realmente cómo navega el paciente es fundamental. Una visión de enfocarnos en el paciente, entender las dificultades de cómo va navegando el paciente a lo largo del sistema para realmente apoyar. Por supuesto, la formación, siempre estar preocupados por el estado en el que se encuentra todo el personal de salud.
Really pay attention to how the medical staff is educated. We talked about the mission of filing a predictive, preventive, predictive system of the patient with the piece is important. We have to use a depersonalized system, but we have to feed the system. It's a key important, the data-driven way of working, and it brings us back to what Margareta said, because this is going to help us, for example, for that imaging system of where cancer is located for better treatments. Both of your visions are very important. Now, Cynthia Villarreal, Director of Medical Oncology, Breast Cancer Center. In a brief way, I would like to take 2 steps behind to talk about the landscape here in Mexico. What happens with breast cancer? Well, breast cancer is the most frequent type of cancer in Mexico and the world, and it causes a great mortality. And for 2040, the number of women will increase. This is a world health problem. Something that is very important is that survival of a breast cancer patient depends on what is the stage where it emerges to you, where you really discover it. If you discover it at the beginning, you have a great percentage of probability of survival. But if you really discover it in a later stage, it is more difficult. We need two components to decrease mortality, that it is early.
A los pacientes a este tratamiento. Para la detección temprana, que es en lo que me quiero enfocar en estos breves minutos, tenemos dos grandes categorías. Uno es el escrutinio o tamizaje, en el caso del cáncer de mama.
Scrutiny is the mammograph for suspecting symptoms to make an early detection, and the other is the early diagnosis, where women with symptoms are followed up until you get the diagnosis. To the early detection or early diagnosed, we have a great range of events, since the patient identifies a symptom or a problem until the moment she starts treatment. This is a whole framework, a whole line of time. It is important to know and understand that we cannot decide what she does in her house, but we can do things at hospitals or in the healthcare services, and it doesn't have to go beyond 90 days. In Mexico, most of our patients are detected in stage 3 and 4, and the results are more negative. We also know that in our country or countries like Brazil, 90% of the patients detect that they are sick when they already have a symptom. Now, regarding tests, if we want to consider a program successful, the target population must be covered in a 70%. We can see that in 2011, mammograms only covered 11%. The reality is 22%, so we are very far away to be considered a good scrutiny program. When a patient touches herself and discovers it until she starts getting treatment, there's a long time that goes by. We made a research of 900 women that were treated in 4 hospitals, and we saw that the patient, in less than 10 days, she goes to look for help. But the total interval to start treatment is 7 months. That is an enormous amount of time. 90% of women that start with the medical treatment should start in 4 months. This is the timeline of a woman. These are the whole number of appointments that she has to go to until she starts her treatment. 11 or 12 appointments. That is too much. This is what the patient says. I don't want to go again. If they send me somewhere else, I won't go anymore. So she had a delay in her treatment of 13 months. The delay was very, very important. Sometimes it is difficult to establish in the different countries to establish a test program. So we have to focus on the early detection of the disease. The most important proposal is to detect and prioritize patients with symptoms and be agile with them. Here we have a problem. This is an example in Brazil. What happens if we only concentrate on mammographs? Even if we cover 80%, remember that Mexico 23%, they would avoid 2,500 deaths. In scenario number 2, if 80% of patients in stage 3 or 4 would be diagnosed in stage 2, 7,500 deaths would be avoided. And in scenario 3, if 50% of the patients in 3-4 would be detected in stage 2, we would avoid 4,700 deaths. We know that there are examples in Mexico, particularly this Alerta Rosa, Pink Alert, that is a program we have in Nuevo León, are useful. There we categorize and classify them in the World Health Organization mentioned it in the International Day of Health about this Alerta Rosa program. So instead of making a patient going to 13 appointments, maybe we could improve things, asking them to go only to 1 or 3 appointments, and that would help us. Thank you very much. Yes, Cynthia, this is very important. To diagnose in a timely fashion is very important, in a very timely and manner thing. And also the treatment. The treatment has to start on time. In the Mexican Association, we are working with several circuits that have to do with lung cancer, breast cancer. The suffering of the patient when navigating through the system is terrible. We have great challenges. We have to support patients. We have to help. We have to reduce the number of appointments, the number of time until they start their treatment. Sometimes patients abandon treatment because logistics are totally complex or unfeasible due to costs. And also we have to pay attention to the difference between rural areas and the city. What Cynthia has done is very important. I remember that you went to the rural areas to analyze. Now I would like to hear Maria Fernanda Navarro. She is in charge of the City Cancer Challenge, and she has several experiences, and we would like to hear your vision. Thank you, Hector. Good afternoon or days. Thank you for the invitation. City Cancer Challenge is an initiative that was that started in 1917. And they look to support countries and cities in poor or poverty conditions. From the beginning, this initiative wanted to create a micro environment, a city environment, to find local conditions, to work up the ladder and generate impacts at a local and state level. So we started working in Cali, Colombia, and other 2 cities, trying to attract all the interested people in the cancer subject. And just as you said, all the parts have to be involved. Representatives from the government, local government, universities, and of course we have people from Tec de Monterrey, also public and private clinics. And in Mexico, it is much more important due to the fragmentation of the health system. We also bring specialists in cancer, cancer institutes, and other players, public and private. And this taught us how to innovate. So we decided to innovate in Cancer Challenge. We wanted to innovate this process. We went to the cities for 2 or 3 years, and we really the way to improve access with more quality, empowering professionals. This has been a very interesting experience. After learning and with the innovation, we have succeeded in the city models in Latin America. We have 5 cities now. We have Paraguay, Arequipa in Peru, Colombia, and León in Mexico, in Guanajuato. We've been working in León for a year. Many doctors, public and private, teachers, universities, social society. That is a very important part of our initiative in order to understand local needs. And this is also based in our innovation analysis. We make an analysis of the needs. We focus on the gaps, how we can bridge them, and how to prioritize them. What we are looking for is collaboration among all the parties. Of course, we are working with the TEC de Monterrey in León to understand what has been done, because we want to help and leverage existing initiatives. After understanding the needs, we start with the situation analysis report that we will present it next week. I invite you to the webinar where the local leading specialists will be there, as well as the more feasible solutions. That's the way we work, and that's what we have done in León. Of course, we still have a long way before us to see all these initiatives put into place and go from the local to the state, regional level. We have all the stakeholders, the Atomic Energy International, the Pathology Clinical Association, the Oncological Association. We have breast cancer, breast initiative. We are aligned with the WHO and all these international stakeholders so that they can support these cities when they find the solution, and they can tell them, yes, this is feasible or not, you can do it this way according to the needs of the city. They are not external solutions. They will be local solutions based on real needs that are culturally adapted. I'm happy to hear you. Thank you very much, Fernanda, Alex. Society is actively participating. Jaime and Santiago are with you in this León case, and we also were selected to be actively participating in this case. I would like to talk about early diagnosis. This is interesting, and Margareta talked about it. She said we have the technology, but how would we or how could we reduce times? And if there's enough space to use the technology. So I would like to ask Margareta and Cynthia, what do we specifically do to incorporate the mentioned technology in Mexico, and that we can use artificial intelligence in terms of mastographies to reduce time. So Margareta, I would like to hear.
Quite good presentation also that Cynthia that is showing what's the effect, what they've seen. Do you see really in AI an opportunity to reduce the time to treatment, to diagnosis and treatment, and how should you recommend incorporating this into Mexico first?
Well, I think AI can really help us improve the efficiency of looking through, for example, in breast cancer with mammograms. AI can screen thousands and thousands of mammograms very quickly. And not only can they do it, the AI can, not only can it do it quicker, it can see things that we as human beings can't see. So for example, on a mammogram, there's 65,000 shades of gray, different gradations, but the human eye can only see 256 shades out of 65,000. The AI can see all 65,000. And the very newest algorithms that have been designed in Hawaii at the University of Hawaii Cancer Center is actually analyzing the composition of the breast tissue. And I've seen the images, and they're really interesting. Basically, the AI can look at a piece of tissue and that's suspect that the doctor might think is cancerous, and it can tell if it's malignant by analyzing the lipids, the protein, and the water content of the tissue. And that's brand new. That paper was published in September of 2021. So AI, not only can it make things faster and can give more people access, it can actually analyze the composition of the tissue, which is really great. And the thing that I'm the most interested in about AI is that it gives access to people all over the world, but also access to the best. So the same algorithm that would be used in San Francisco at the best hospital to screen mammograms can be used anywhere in the world. And some of those algorithms have already been shared with hundreds of hospitals around the world. So, and I think it would be really interesting to see which hospitals. And I was trying to do that. Before this panel, I was trying to find out which hospitals are using all these algorithms that I tell, because there's no registry that tells who's using what. But I think that would be a very good research project for me to do, to see, because every time I talk to their researchers and the companies, they always say this is being used in 100 hospitals, but they don't tell me the names of the hospitals, and one other really great thing about using AI is I've seen 2 different devices that are about this big. They're very small, that can be used to screen women for breast cancer. One of the devices is being used throughout the Pacific on 2,000 islands all over the Pacific, where there's no hospitals. There's only one cancer hospital in the entire Pacific, and that's in Hawaii. So they have these little devices that have AI embedded, and they screen women on islands throughout the Pacific, and then all the data is sent to Hawaii, where radiologists look at it. That's really good. And then there's another device that's been cleared by the FDA that's being used all over India. It was actually designed by a woman who has a PhD in AI. And it can be used in places without electricity and without internet access. And it can screen women for breast cancer. And they've already screened 80,000 women in India. So anyway, the things that are the most exciting to me is that women anywhere now can be screened for breast cancer. And there's so many women who didn't have access to hospitals.
That's exactly the point, how we can bring this technology. When you're sharing this example, like in India, that's what we require in Latin America. When you look inside the countries, inside the different countries in Latin America, how we can work through that. Cintia, ¿cuál es tu impresión del uso de estas tecnologías y cómo lo ves pasar, digamos, a hacerlo realidad en México? A lo mejor estás en contra de la tecnología, no lo hemos platicado, o a favor, pero nos encantaría escuchar tu punto.
I would like to hear your point of view, if you are for or con technology. No, of course not against. I think it can add up to early detection. However, there are many challenges. So to start, I would say that in Mexico, it is a reality that most mammographs are analog, where images are printed with bad quality, and these prints have to go from the diagnostic place. And in that transition, we really extend the framework of time or the timeline. Something else is that in order to interpret this test, we need a specialist. Not any radiologist can interpret a mammograph, and we have few expert radiologists. So many times she goes to a not very good quality place. The results cannot be read, and it is interpreted or read by a non-expert person. person. So it is very frequent that a person with breast cancer in a more advanced stage takes long to receive a good, or at least to start receiving treatment, even when she went on time. So it would be good to concentrate all these tests that have to be read, and this can be done remotely by an expert. And I would like to emphasize something else, and I don't know if it's part of the technological part. The scrutiny mammograms go together with the diagnostic mammograms. These are when the patient herself is saying, yes, I'm feeling a problem, I'm feeling a pain, I'm feeling a symptom. And I think there should be two different groups, the ones that to be interpreted or read, the ones that are just having a normal checkup, and the others are the ones that already have symptoms, and those have to be prioritized so that they get in a more agile way. Yes. The question is, how do we incorporate this technology with the challenges that Dr. Villarreal is mentioning and do it in the correct way? One has to be for people that are already in the center, and how to get together all these technologies to have an early diagnosis. Now, Ale and Fernanda, let's talk about information systems, and how do we take advantage of them for the decision-making process. Fernanda, you talked about cancer records. How are in regards to information? And also later on, Alex, please, you can tell us what you are doing in OCAN. Okay, Fernanda. Well, in South America, cancer records exist for 19% of population. We are bad, but not, for example, as bad as in Africa. They are 14%, but there's still a long way to go. Efforts of the ER to strengthen cancer records in different countries are important. We have seen efforts, for example, Paraguay, Asunción, Paraguay, they are strengthening the initiatives and the challenge. They are working to make this cancer record real in order to digitalize these records. The Cali record is a good one, Cali, Colombia. They have a high quality of information, and this allows the decision makers to decide if interventions have an impact, if they are going to take 2, 3, 5 years. In Mexico, they do not exist. We've made some initiatives. There was an approval in the past, a federal approval, where they allocated money so that they had cancer records. For example, in León, Guanajuato, this was supposed to be a city that was accepted. Unfortunately, it is not within the law anymore. So that is totally obsolete. It is frozen. There are also initiatives from the representatives. On February the 4th, that is the World Day for the Control of Cancer, that was priority number one that they presented in the representatives' house to start with the record. Data, the data aspect is important, is key. to make decisions, to notice or to decide what are the changes that have to be done to handle the different patients.
Your impression about data and the use of data in cancer, and what are you doing in OCAN to improve or to incorporate initiatives that would help us do better diagnosis and treatment of cancer?
Thank you, Hector. So I think if we're looking at the innovations and I'm sorry, the only areas that I can understand was what Margareta was sharing in English. But I think investing in primary prevention of cancer is another areas that can probably have the most efficient long-term cancer control strategy. If we think about it, it can avoid far higher downstream costs associated with the diagnosis and treatment and sort of socioeconomic impact of cancer as well as the impact on patients themselves and their families. So I think some of the areas that I'm drawing sort of from Allcan's position on data would be creating policies that address sort of known modifiable risk factors within the population that we can address, implementation also of evidence-based public health measures, such as vaccination against cancer-causing viruses, for example. And the thing that I mentioned as well about cancer health literacy among the general public is also important for both, I think, prevention and cancer care as well. So I think that comes from sort of a preventative part. When we move, as we move forward, I think that our healthcare systems do harness evidence-based innovations, and again, learning about the AI aspects is really, really interesting. And this applies in all aspects of cancer care. So I think from diagnostics, from throughout the whole cancer care continuum, and where these can improve the efficiency of therapy, but also keeping the equity challenges in mind, so making sure that we have equitable access to these. Ongoing sort of learning and assessments of our healthcare systems and the processes that we have in place, and making sure that we are adopting innovations in how care is organized and delivered, so not just by using specific technologies or therapies as such, but really looking much more broadly, how can we use innovations to create these efficient practices. So for example, employing telemedicine and remote patient monitoring measures equitably where they are appropriate. So for example, where these improve efficiency while also delivering high quality care that meets patients' needs. I think examples that were shared with the Pacific region, the use of sort of tools in that area was great. And I think in COVID pandemic as well, we've had, it's shown as how telemedicine services can be useful. So allowing patients to access care without visiting the clinic. But I think it's always important to stress that patients often value face-to-face interactions and consultations. So really it's important that these do not replace, let's say, routinely the appointments and consultations with patients, but we use it to enhance and to improve access and using the innovative tools to do that.
So thanks, Alex. Quite interesting. Just I want to wrap up with the four of you. Have a quick wrap-up message. It's interesting, and I would like to hear in your wrap-up message your impression. We concentrated a lot in using AI in diagnosis, but also Margareta at the beginning said it was critical to use AI in the correct definition of which treatment should be used for which type of cancer and specifically in which patients. So please consider that in your last message, and happy to hear you. If you want to start, Margareta, please do so. You're in mute, Margareta.
Okay, there you go. The most exciting thing about innovation right now is how quickly it's happening. And so and it's not happening over a period of a month, it's happening over a period of days and weeks. So for example, at Stanford, typically if we're going to use, we're going to, sequence the genome to diagnose a patient who has a certain type of cancer, or other diseases, it usually takes, when they're doing it very quickly, 3 weeks to diagnose it. But just last month at Stanford University, they were able to sequence the genome of a baby in 5 hours and 2 minutes, and then diagnose the baby 2 hours later. So in 7 hours, they were able to do to diagnose a patient, and you usually take 3 weeks. So, and I talked to the doctors who did this, the scientists, and they said they can cut that time in half. We're using AI. They can do it in 2 hours. So see what I mean? And this happened in just the last few weeks. So I think the thing that's going to surprise everyone the most is how quickly the innovation is going to happen. So something we don't have today, we can have it in a month, and it can be astounding. So that's the most, I mean, imagine being able to diagnose your patients in an hour or two.
No,
It's amazing, you know, so that's
amazing. And we should be,
and it's happening at the best, it's happening at Stanford and MIT and the best university. So it's not fringe. This is very reputable scientists are doing this. And it's, I don't even think people realize what's happened just in the last couple of weeks, but things are really speeding up. And so it's very exciting. By next year at Innovation Week, we should have a lot of great improvements since this year, like big things that we can see over the next year.
Thank you very much, Margareta. Thanks for your comments. And it was, as always, very nice to hear you. Please, Cynthia, si nos compartes un último mensaje.
Cynthia, if nada you más, share a last message, well, I would like to make a step behind. Margareta was saying that in one day we can have a breast cancer diagnosis where they have all the structure. Here, 90% of women really do not have ready a diagnosis in 3 months. And sometimes 6 months. So I am a clinician. What do we do so that experts in productivity, in efficiency, help us to reduce these times, starting by bridging the gaps, and patients can come in a more direct way to have reference effective patterns, navigation systems, walking with them hand in hand and go wherever it takes. So I think these are the most important elements where we have to focus. Thank you, Doctora Villarreal. It is a pleasure to hear your opinion. Thank you for your participation.
So in closing, I would just say that I think the impact of the pandemic specifically, I think if we looking at the most immediate terms, we have in Europe, European Cancer Organization estimates that over 1 million misdiagnoses were missed due to the pandemic over the last 2 years. I don't know, maybe you may have the data for this for Mexico as well, but if we look from global perspective, the fast, rapid advancement in sort of AI technologies or innovation can help us really to tackle these delays and to really address the sort of backlog and ensure that we can get to these patients as quickly as possible. So sort of looking at investment in diagnostic capacities and looking at innovation that can improve the efficiency the rate at which we can make the diagnosis, the correct diagnosis more specifically. If it can be done in an hour, you can only imagine the impact that you can have, especially in remote communities. And lastly, in addition to that, I think we need to have sort of referral pathways which can take the diagnosis then to ensure that patients can have access to specialists as promptly as possible following that diagnosis. So I will stop with that. I think there's a lot of different aspects, but if this is the one to focus on, I think that tackling the impact of the pandemic on misdiagnosis, and I'm very excited in the direction that this is going in terms of research.
Thanks a lot, Alex. Fernanda, por favor.
Bueno, para cerrar, creo que es muy Fernanda, please. Well, to close, I would like to emphasize something that Margareta said regarding those developed economies. We have to think on going up, understanding the needs, how meeting these needs can give us solutions with technology. but we have to do it understanding first the problem and then use the technology, not starting from trying to apply the technology. And that has to be done in some countries like Mexico, where we have a fragmented medical system, where patients might have equipment around them for the diagnosis, but if they are not holders of these rights from the Social Security or ISSSTE, they will not be able to use. So we have to work cross-functionally to improve, to enhance their access to the medical sector. Thank you for all your participation, and I will summarize it this way. First of all, we have to always remember that our focus must be patients, and we have to work to reduce traumatism or the so much accidented navigation of the patients. Then to renew and revisit the possibility of having a cancer record that allow us to have models for those diseases data-driven, to use the analysis to build the right building blocks of the information. Third, the importance to incorporate artificial intelligence for a timely diagnosis and for defining what kind of treatments for what kind of patients and what kind of cancer. We saw examples from Hawaii, Stanford, India, MIT, other cities in Latin America. So we have a lot to learn and join them. We have to work in prevention. We have to work on many things. It has been a pleasure to work coordinating this panel. Thank you, Chris, Carla, to give us five the opportunity to work in this panel. We are willing to work together, focusing on the patient and reduce accidents in the navigation of patients through the medical system, as well as having an early detection so as to start immediately the treatment. Chris, I give you the floor. Thank you, Hector, for your moderation. Cynthia, Fernanda, Margareta, Alex.
A lot of work to do. You elevated the bar. Thank you very much. Y simplemente a todos y a todos
Simply, I would like to wrap up by thanking you for connecting, for participating face-to-face. Thank you for being here in the first day. Tomorrow we will start at 8 o'clock. We will have clinical investigation tomorrow. It is an important subject of the process to bring innovation to the market, and then a panel to talk about the impact of new technologies as of the pandemic and how we can reach efficiency in this regard. Thank you to you all. Good afternoon.